you? How are you all doing?
You're fine.
That's great. That's great. Welcome to another session of cardiology. Today we are going to talk about congenital heart diseases.
Yeah.
Okay, as you know that there are acyanotic and cyanotic congenital heart diseases, so we will talk about them separately. First of all, we will start with the acyanotic. So, acyanotic, as you know from the name, that there will be no cyanosis in these diseases, congenital heart diseases, but there is a classification how we are going to classify, because there are so many heart diseases. Sometimes you mix up them, whether it is cyanotic, acyanotic, it is right to left shunt or left to right shunt, what will be the pressures, what will be the volume. So this is basic classification of the acyanotic heart diseases. So they are divided on the basis of volume overload and then the pressure overload. There are some diseases which causes the increased volume within the heart and within the lungs, so ultimately they are going into the heart failures. And there are some congenital defects which are going to increase the pressure instead of volume, so they are not going to present with the heart failure but some other sign and symptoms depending upon the degree of their obstructions or whatever. So, first of all, the acyanotic, which are presenting with the volume overload. So, the acyanotic, which are going to cause the increased volume within the lungs and within the heart, these are left to right shunts. As we all know, what are they? This is the atrial septal defect, then ventricular septal defect, patent ductus arteriosus, and AVST, atrioventricular septal canal defects. These are also called as the endocardial cushion defects. So these are basically, we have known that these are the acyanotic congenital heart disease, which usually present with the heart failure. These are left to right shunt, which means the shunt will be from the left ventricular to the to the right ventricle. Or if it is the case of atrial septal defect, then it will be from the left to the right atrium, because the left side of the heart has higher pressures as compared to the right side of the heart. So these are the congenital defects which are going to present with the volume overload, and these are acyanotic defects with left to right shunts. Then what is the other category? Other category is the pressure load. These are going to cause the increased pressures, and these are ventricular outflow obstruction defects. And among them, there will be pulmonary stenosis, aortic stenosis, and coarctation of aorta. It's not necessary that these will also be present with the heart failure, because there is variety of obstructions, degree of the obstructions, like in peripheral, in the pulmonary stenosis. It could be mild obstruction, it could be moderate obstruction, or it could be severe obstruction. The severe obstruction will present with the stenosis in the even neonatal period. Similar is the case of the aortic stenosis. The sign and symptoms will depend upon the degree of the obstruction, as this is ventricular outflow obstruction. Okay, this was simple left to right shunt, which means there is defect and there is going to be left to right shunt. But this is basically the obstruction to the pulmonary, at the level of the pulmonary valve. It is the level of the aortic valve, and then coarctation of aorta. We will talk about its pre-ductal and post-ductal constriction in the aorta. So these are all going to be about the obstruction, and what are the sign and symptoms will be of these diseases. They will depend all these three diseases. It will depend upon the degree of the obstruction, and this degree of obstruction which then classify, or will you can say that will classify about the pressure, what will be the pressures: high pressures, moderate pressures, or mild pressure overload in the heart and the lung accordingly. So this will acyanotic congenital heart diseases, these are divided on the basis of volume overload and the pressure overload. And among the volume overload, this is basically because of the left to right shunt. Among them is the AST, VST, PTA, and the AVST. We will talk about one by one each of these. And then other one are the pressure load, which are going to cause the increased pressures in the heart. And these are those diseases which are going to cause the ventricular outflow obstruction. You are saying that this is ventricular outflow obstruction, which means from the pulmonary valve, the blood is going from the right ventricle to the pulmonary artery through the pulmonary valve. So that is the outflow tract, and the obstruction of that will be pulmonary stenosis. Then the left blood is going from the left ventricular to the aorta through the aortic valve. So that will be the other outflow obstruction of the ventricles. That will be the aortic stenosis. And the coarctation of aorta, it will be the constriction at the level of the aorta, descending aorta. So it's also, that is the outflow tract of the left ventricle. So these three are the ventricular outflow obstruction which are going to increase the pressures in the heart. Now we will talk about one by one these all diseases. First, we just get an overview of this. The first one is the acyanotic with the volume overload. What is going to be caused by left to right shunt. There will be a communication between the systemic and the pulmonary sides of the circulation. You can say, what is the communication? It could be a ventricular septal defect. There will be communication from the left, that is the systemic, going to be systemic, and the right ventricle, that is going to be pulmonary side. So it is a communication between the systemic and the pulmonary sides of the circulation, which will be results in shunting of fully oxygenated blood back into the lungs through a second passage. Like in case of ventricular septal defect, we are from the left ventricle to the right, it is going to be blood coming from the left to the right ventricle through a VST, and then from the right ventricle it's going into the pulmonary artery, and then from there it's going into the lungs. So basically it's a communication between the systemic and the pulmonary sides of the circulation, which will result in the fully oxygenated blood from the left ventricle to the right ventricle, and from there to the lungs. And increased volume of the blood in the lungs, then what will cause decreased pulmonary compliance, and there will be increased workup breathing, because we are pulling the lungs with the blood and the blood and the blood. So their pulmonary compliance will decrease, and there will be increased workup breathing. Fluid will leak out into the interstitial space and the alveoli, and it will cause as the pulmonary edema, and the patient will present with the heart failure signs. So this is the reason that left to right shunt defects, they are going to present with the heart failure. So you need to remember this, because there are three main clinical situations with which these congenital heart defects are going to present. One is the cyanosis, second is the shock, and third is the heart failure. So I have made a table I have summarized all these things at the end in 3 to 4 tables, so you will get that. But you need to remember which congenital heart diseases are going to present with the heart failure, which one are going to present with the with only cyanosis, and which one are going to present with the shock and somehow some degree of cyanosis also. So these are their clinical presentation, which are different from each other, and on the basis of the clinical presentation you are going to diagnose those scenarios which are given in the extended matching or in the best of 5 questions. So just one thing I need to clear here, that you will be asked in the task and the FOB both. You will be asked about the diagnosis on the basis of clinical signs and symptoms and their investigations like chest X-ray and the ECG findings. So the part about the management, you will not be asked. That is the part of basically AKP. So I have not emphasized in this lecture on the management. Just an overview of management is given, but I am going to emphasize on the clinical sign and symptoms, the clinical examination, the type of the murmur, what will be about the first heart sound, second heart sound, and then what will be their ECG findings and what will be their chest X-ray findings. So you need to focus on these things. So this was the when there will be left to right shunt, and the blood is going from the right, increased blood flow into the right ventricle, that is going to be into the pulmonary artery, and from there into the lungs. That is going to cause the fluid leakage in the interstitial space and the alveoli, and ultimately it's going to cause the pulmonary edema, and the patient is going to present with the heart failure, which will be obviously in a neonate or an infant. It will be tachypnea, tachycardia, and there will be sweating, chest retractions, nasal flaring, and wheezing. All the signs of respiratory distress will be present. And what about the pressure overload? What is we talked about? This is about the obstruction to the normal blood flow, that is obstruction to the ventricular outflow tract. So there will be stenosis. The valve will be stenosed, either it is pulmonary valve or it's aortic valve, and so there will be obstruction which will lead to the backflow. So if the obstruction is mild, cardiac output will be maintained, and the clinical symptoms of the heart failure will either be subtle or absent. And heart compensates for the increased afterload by increasing the wall thickness. So, as I talked about, the sign and symptoms will depend upon the obstruction degree of the obstruction, whether it is mild or moderate or severe. If obstruction is mild, what is going to happen? Like if there is the aortic valve and its obstruction is mild, there will be some degree of obstruction to the outflow of the blood. So that blood will backfire into the left ventricular, and there will be increased pressure in the left ventricle. How the left ventricle is going to compensate for this increased pressure? It's going to cause the increased valve thickness and hypertrophy, which will lead to the left ventricular hypertrophy. And there is not so much blood, so it will not regurgitate back into the left atrium and then back into the from the pulmonary veins into the lungs. So there is not going to be so much pooling of the blood back into the lungs, and the patient there will be subtle or no signs of the heart failure will be present in the mild degree of the obstruction. But what about if it's severe degree? Obviously, that is going to present in the immediate newborn period, because there will be severe obstruction to the outflow tract, either it's aortic or it's pulmonary, and it will lead accordingly symptoms. And initial infant become critically ill within several hours of the birth. So whenever there is severe outflow obstruction to the ventricular outflow tracts, it is going to present in the immediate newborn period, and the babies will be critically sick. And what are these three conditions? These are the critical pulmonary stenosis, critical aortic stenosis, and preductal coarctation of aorta. Among pulmonary stenosis and the aortic stenosis and coarctation of aorta, these are the severe forms which are going to present in the neonatal period and with heart failure in the immediate newborn period. Their mild and the moderate degrees, they can present later in the childhood, or the patient may remain asymptomatic. Like if it's post-ductal coarctation of aorta, it will be asymptomatic until it will be diagnosed in the later childhood. Similarly, is the aortic stenosis, it will also be asymptomatic until later in the childhood or the adolescent, and the patient is going to be diagnosed on the incidental finding, or maybe there some history of the palpitation or chest complaint. And similar is the pulmonary stenosis. It's various degrees, and the associated anomalies will determine how it's going to present in the later life. But these are three varieties. Among the pulmonary stenosis, the severe degree is called critical pulmonary stenosis. Among the aortic, the critical form called as a critical aortic, and the coarctation of aorta, its variety preductal, is going to present in the neonatal newborn period, and it will present as the heart failure. So now we're going to start with the ventricular septal defect. Okay. TS is the tricuspid stenosis. Tricuspid atresia is a congenital heart disease. Tricuspid stenosis is not, I think, as far as I know that. Tricuspid atresia is going to, it's a cyanotic congenital heart disease, and it's going to present with cyanosis. Pulmonary stenosis, it's a mixed variety. The severe form will present as a critical pulmonary stenosis in the neonatal period, while the other forms, they will vary depending upon the degree of. So first we are going.
Sorry, just a minute. So how we classified pulmonary stenosis or aortic stenosis under the cyanotic heart disease? My question is that.
Sorry, can you repeat the question?
I'm saying how you classified pulmonary stenosis or aortic stenosis under the cyanotic heart disease?
Yes, I give you the exception here. that the only critical aortic stenosis is the cyanotic congenital heart disease, which it will not be cyanotic. It will present as the heart failure in the newborn period. Do you know how the aortic stenosis patient present in children? What are the signs and symptoms of a baby who is having aortic stenosis? They are going to present. What is the clinical symptom? What is the clinical presentation of the patient who is having aortic stenosis? Can you describe, please?
I know, ma'am, that critical aortic stenosis neonate present with severe heart failure.
Yes. Critical aortic stenosis presents with the severe heart failure. It will not be cyanotic. The cyanosis that come in the critical aortic stenosis, it's the underlying pathophysiology secondary to the heart failure. It's basically, that's not a cyanotic congenital heart disease. It's only the critical aortic stenosis which is having severe obstruction. So there will be very low systemic circulation. There will be no systemic circulation. No blood is going to the aorta and from there to the upper and the lower body. So that's how the baby is going to present with the heart failure. There will be low palpable pulses and the tachycardia and the hypotension. And while the other aortic stenosis, which is mild to moderate obstruction, they are going to present later in the childhood, and that will also be an incidental finding. So it come under the heading of the acyanotic congenital heart disease. Similarly, is the coarctation of aorta. Only the preductal variety of the coarctation of aorta is going to present with the heart failure. That will be in the newborn period. The postductal is going to present later in the childhood or even in the adolescent, and that will also be an incidental finding. And similar is the case of the critical pulmonary stenosis. It's something different. Pulmonary stenosis has different varieties from the which is different from these two. But the main thing is that it comes under the heading of the acyanotic, and then we classify it accordingly, whether it has VST, it has AST, whether it is associated with the coarctation of aorta or it is associated with the TOF. And then it's there are a lot of varieties of it. But what you need to remember is that they comes under the heading of the acyanotic, and among that they come in the classification where there is increased pressure overload. Have you seen the initial classification which I showed you?
Yes, ma'am. Only I got your point. You said it after the severe heart failure, cyanosis may occur or not occur. So in the basis of the pulmonary stenosis, there is no cyanosis. But after the severe heart failure, maybe. Okay, I got it. Yes, thanks, ma'am.
Yes.
Thanks.
I will explain it. I will explain it later, one by one, each and every congenital heart disease which I have mentioned here. This is just the basic which I am giving you. We will discuss all these here. 2, 4, 5, 6, 7. We will discuss all these one by one, and I hope so that your point will be clear in that when I will explain all this about depending upon their severity and their clinical signs and symptoms. So we are going to start with the left to right shunts. That will be the AST, VST, PD, and the AVST, and after that we will cover the PS, AS, and the coarctation of aorta. So it will be clear, inshallah ta'ala.
Okay, sure.
So what is the first thing is that ventricular septal defect. So it is the most common congenital heart defects in the children, most. So, and there are 3 types of ventricular septal defect depending upon their location. One is the membranous, second is the muscular, and third is the supracrystal. And among them, membranous is the most common. And this classification is categorized upon their location where the VST is going to be present. What its underlying cause, it's membranous, it's muscular, or it's supracrystal. And depending upon their size, there are 2 types. One is the small VST and second is the large VST. Can anyone explain what was the embryology of the interventricular septum, which we have covered in the lastly in the last session? How interventricular septum is going to form? How many parts it have? Okay, I will explain it again. As you know that this was the heart, it was the right ventricular, it was the left ventricular, and this was the muscular portion of the interventricular septum, which was going to be proliferate from here. And then from the septum intermedium, the other part that will be the membranous portion is going to form, and together they are going to make the interventricular septum. That is the normal embryology, normal the heart. What is going to happen when there will be no portion from the septum intermedium? The membranous portion is not formed here. Then this is called as the membranous VST, causing left to right shunt. And when there is the muscular portion is missing, or it's not completely formed of the interventricular septum, then it's going to cause the muscular VST. It's going, and this is going to cause the left to right shunt. Both are going to cause left to right shunt, but depending upon the location. If the muscular portion is missing, or it is not completely formed, then it is called as the muscular VST. And if the membranous portion is not formed, or no, it is incompletely formed, then it is called as the membranous VST. And both are going to cause the left to right shunt. That's why I told you, that the embryology is very important, even in the VST, in the AST, in the AVST. Then it is in the hypoplastic left heart syndrome and the coarctation of aorta, many things in truncus arteriosus, in which all this embryology of the heart is going to apply. So you need to remember how the interventricular septum was formed, how many portion it have. It has a muscular portion, it has membranous portion. So when the membranous portion is missing, then it is going to be called as a membranous VST. And when this muscular portion is missing, then this is going to cause as the muscular VST. And the membranous VST is the most common type of the VST, but it is the most common, but it's not going to close spontaneously. The spontaneously closure of the VST is going to be caused by the muscular VST. I will talk about later. This is important thing to remember. So this was the last classification was on the basis of the location, while this classification is on the basis of the size of the VST. When it is called, when there is a small communication between the left and the right ventricular, which means the size of the VST is less than 5 millimeter, then it is called as the small VST, or it is called as the restrictive VST. The right ventricular pressure will be normal. Why it is called as a it is also called as a pressure restrictive VST, because the size will be very small and the shunt will be very small. So the very small amount of the blood will be shunted from the left to the right ventricular, and the right ventricular pressure will be almost normal. So left to right shunt, it will be because due to high pressure in the left ventricular. So when the VST size is less than 5 millimeter, it will be called as a small VST, and it will be pressure restrictive, and the right ventricular pressure will almost be normal. There will be not that much change in that, and there will be left to right shunt, because obviously the left side of the pressures are high as compared to left. So it will be from the high pressure to the left pressure, the shunt will go. And when it is called as a non-restrictive, when there is a large communication that is about greater than 10 millimeter, then we are going to call it as a large VST, and it will cause as the pressure non-restrictive, because right and the left ventricular pressure will almost become equalized with the passage of time, not at the presentation, but with the passage of time, because of a very large shunt that is going shunting the blood from the left ventricle to the right ventricle. Almost the right and the left ventricular pressure are going to be equalized, and this is the type of the VST, that is the large VST, which is going to present with the heart failure. The small VSTs do not present with the heart failure, and they usually spontaneously close, and we don't need much treatment in that. We just need observation. While this is the type that is the non-restrictive and the large VST, which are going to present with the heart failure, and which will ultimately lead into the Eisenmenger syndrome if they're left untreated. So you need to remember this difference, that not all type of these diseases the diseases, the defects which I am telling you that they are going to present with the heart failure, it's not that they are just going to present with the heart failure. It depends upon their degree, upon their size. What is the size of the defect? What is the shunt? What are the pressures? So all of these things collectively going to determine what will be the clinical sign and symptom of this disease. So in case of VST, it is the small VST. It is just going to be an incidental finding, or the patient may present with pneumonia and you just auscultate the heart and you find out that there is a VST. And you are just going to observe that, and depending upon the degree and after the echo and all these things. But this is the type of the VST, that is the large VST greater than 10 millimeter, which is going to present with the heart failure, because there is a very huge shunting from the of the blood from the left to the right ventricle, which is going to from the pulmonary artery into the lungs. They are going to pull up the lungs with the blood, and then there will be pulmonary edema, and the patient is going to present with the heart failure. And with the passage of time, when it's going on and it's going to be left untreated, then the right and the left ventricular pressures may become equalized, and there will be a time come when the right ventricular pressure over exceeds the left ventricular pressure, and then the shunt will be reversed from the right to the left, and it is going to cause the Eisenmenger syndrome. We will talk about also later in the presentation. It's just to give you an overview. And here the basically shunt depends upon the pulmonary vascular resistance to the systemic vascular resistance ratio. You just need to remember this thing. And how it's going to present, what will be the clinical examination findings. This is left ventricular here, and this is the right ventricle, and here they are showing that this is the VST. And then there will be left to right shunt. From the right ventricular, it's going into the pulmonary artery, and from here it's going into the lungs, and they're going to pull up the lungs. And there will be a pan-systolic murmur of VST that will be heard at the left low sternal border. It is pan-systolic. It means you will heard it throughout the systole. It will not be systolic, that it comes just in the one part and it is missing in the second part. No, but why it is called as the pan-systolic, because you will heard a almost same, you will heard a same intensity murmur throughout the systole, and there will be loud P2 second heart sound. The P2 component, pulmonary component, will be loud because of the development of the pulmonary hypertension. Why? Because you are pulling the lungs with the blood and the blood. So the lungs has to respond to that shunting of the blood. So what they are going to cause, they are going to increase their resistance. So, and ultimately the pulmonary arterial pressure will be higher. Sometimes there is a diastolic rumble if at the apical area you may heard, but it's not that much diagnostic. But you need to remember is that you are going to hear a pan-systolic murmur at left low sternal border. Small VST, it will be loud, harsh, blowing murmur at the left low sternal edge. Why it will be loud? And can anyone tell me that it's small VST but having a loud murmur? What is the pathophysiology behind that?
Yes.
Yes, please.
It's vice versa. If the anatomy is small, the load will be high. And the vice versa, if the anatomy is large, the sound will be small.
Okay. As it will be small defect, but the pressure in the left ventricular is very high. Whenever some, even in case of water, or you can see that when it's going to be, it has to pass from a very small hole. It's going to be passed with a pressure. There will be increased turbulence from that small hole. So this is the same thing in the small VST. There is a small defect, and the blood has to pass with a high pressure through that small defect. So it will create more turbulence because it will try to pass out with the very high pressure. So it will create very much turbulence, which is going to cause a very loud murmur. But in the case of as the large VST, there will be a very large defect. So the blood is going to be very cool and calmly going to pass from the left ventricle to the right ventricular. So there will be not that much turbulence. So wherever there is increased turbulence, that is going to be cause the loud murmur. So you need to remember that in the wherever there is a small defect, there will be loud murmur. There will be loud murmur. So in the small VST, it will be loud, harsh, and the blowing murmur, and it will be at the left lower sternal edge. While in case of large VST, there will be a soft pansystolic murmur implying large. When there will be soft murmur and it will be pansystolic, you will know that this is a large VST. And when there will be signs of the other, like heart failure, there will be signs of the heart failure, you will see that. About that, among the clinical examination finding, one will be the soft pansystolic murmur. Second will be, the second heart sound will be loud. That is the loud pulmonary second heart sound. And there will be left parasternal heave. What is going to imply the left parasternal heave? What does that mean? When we see the left parasternal heave on the cardiac examination. And what does it imply that? Whenever there is left parasternal heave on the cardiac examination, precordial examination, it means that there is right ventricular hypertrophy. Right ventricular hypertrophy. It is called as left because it is on the left parasternal border. That's why it's called left parasternal heave. But it means that there is right ventricular hypertrophy present. It means the defect is very large. It's causing very high pressure from the left to the right ventricle. That right ventricle has to obviously respond to that much pressure and that much pooling of the blood. So it will go undergo the hypertrophy. So you will see the left parasternal heave, soft pansystolic murmur at the left lower sternal border, along with that loud pulmonary second sound. These are the main findings which you need to remember. What we are going to see on the investigations. Obviously, there will be on the EKG, you are going to see the left ventricular hypertrophy. Why? Because blood is shunting from the left to the right ventricular. From the right ventricular, increased blood along with the blood which is coming from the right atrium. They are going into the pulmonary artery. From there, they are going into the lungs. And then all that blood is coming back from the lungs through the pulmonary veins into the left atrium and then into the left ventricular. Ultimately, left ventricular is going to receive all that blood which has ventricular shunted blood shunted into the right ventricular. So it's going to have the increase pressure increase. It has to work which is going to cause the left ventricle to increase work, and it's going to cause the left ventricular enlargement, left ventricular hypertrophy. Along with that left ventricular enlargement and the right ventricular hypertrophy, one thing is because increased blood is shunting from the left to the right ventricular along with all the blood from the right atrium, shunt it to the pulmonary artery and then into the lungs, from the pulmonary veins into the left atrium and the left ventricular. So both left atrium and the left ventricular are going to enlarge in response to this increased pooling of the blood. And along with that, there will be right ventricular hypertrophy in case of large defects of the VST, because there is increased defect and increased shunting of the blood from the left to the right ventricle. While on the chest X-ray, there will be increased pulmonary vasculature. Why there will be increased pulmonary vasculature? Because you are shunting the blood from the right ventricular to the lungs. So there will be increased pulmonary vasculature. And cardiomegaly in cases of large defects, when there will be right ventricular hypertrophy and the left ventricular hypertrophy. On the echocardiography, obviously you are going to see the defect size. What is the size of the defect? Then what is the shunt magnitude, and many other things which are needed to see. But your focus from the point of examination point of from the TAS and the FOB should be on the X-ray and the EKG finding, which you need to know what is going to happen. If you know the pathophysiology, from where the shunt is going to where it is, from where the blood is going to start shunting, like from the left to the right ventricle, from where and to what extent it is going, then you can easily rule out that whether it's going to be left ventricular hypertrophy, right ventricular hypertrophy, or left atrial enlargement or the right atrial enlargement. So what do you know about the management of the VST? As I told you about that small VSTs, they are going to, we don't need much medical treatment for these small VSTs. We just need observations and they are going to be close. Spontaneous closure occur in most of the VSTs, but membranous VST is the most common, but it's going to be spontaneously closed only 35%. While less common are the second most is the muscular VST, and it is going to be 80% spontaneously closed. While in case of large VST, we need, as these patients present with the heart failure, so we have to give them diuretics, inotropes, cardiac supports, and the surgery we have to perform at the 3 to 6 months of age. What advice we need to give to these VST patients? We need to tell them that you need to maintain the good dental hygiene. You have to avoid the body piercing, and when to seek medical advice. Why it is important? Good dental hygiene and avoidance of the body piercing to prevent the infective endocarditis. And when to seek medical advice, you need to infective endocarditis. And when to seek medical advice, you need to tell them the symptoms of the heart failure, that there will be tachypnea, tachycardia, respiratory distress, and baby will be unable to feed anything. There will be excessive crying. One thing is the heart failure, and the second thing is that you need to tell them about the sign and symptoms of the infective endocarditis, that there will be prolonged fever, and baby will be lethargic, poor feeding, and many other things. What we will see what are the other signs and symptoms of the infective endocarditis in the next slides. So you need to tell them that you need to maintain good dental hygiene, avoidance of the body piercing, and when to seek medical advice. Among them, you need to tell them about the infective endocarditis and the heart failure sign and symptoms. So this concludes the VST. The next acyanotic congenital heart disease with the volume overload is the patent ductus arteriosus. What is PTA? What is ductus arteriosus? Where is its connection? Which structures? Yeah.
It bypass umbilical vein to inferior vena cava.
Umbilical vein. No, that is ductus venosus. I am talking about the ductus arteriosus.
Pulmonary artery.
Sorry, doctor.
It connects the pulmonary artery to the aorta in embryo stage. When baby is in.
It is a connection between the aorta and the pulmonary artery. Okay.
Yes.
And is maintained while baby is in utero.
Yes. And what will happen after birth to it? What will happen after birth?
It will shrink.
After
because the prostaglandin from the placenta has been cut off. So it will occlude and change to ductal ligament.
Yes.
I can't remember it.
Yes. And one stimulus was the prostaglandins from the placenta. What will be the other factor which is going to cause the closure of the ductus arteriosus?
In the aorta.
Sorry?
Oxygen?
Yes. Yes, very much.
Because increased oxygen.
Yes.
The lungs.
Yeah, you are right. It was increased partial pressure of the oxygen in the blood, because after birth baby is going to receive that oxygen from the air. Pressure for lung and it was oxygen, and the second was prostaglandins. One which is going to what were the two trigger factors which were opening the ductus arteriosus? One was the prostaglandins from the placenta, and second was low PO2 of the blood, because it was only 30 to 35 millimeter of mercury of the umbilical vein. That is we are having the maximum partial pressure of oxygen. But what is going to happen after birth? Baby is going to receive its first breath, and it's going to inhale all the oxygen from the air, and that will be the partial pressure will up to the about 70 millimeter of mercury in the blood and in the lung. So that high PO2, high partial pressure of the oxygen, and second was the cut-off supply of the prostaglandins from the placenta. These two were going to cause the closure of this ductus arteriosus. So what is going to happen when it will not close? It will be called as the patent ductus arteriosus. So ductus arteriosus is the connection between the pulmonary artery and
aorta.
Okay, one thing, just so it connects the pulmonary artery to the descending aorta. So what is going to happen? In term infants, it normally closes shortly after birth. As we said that these trigger factors will be cause the ductus arteriosus to close. But what will happen if it doesn't close? In PDA, it has failed to close by 1 month after the expected date of delivery due to a defect in the constrictor mechanism of the duct. So if it is in term, if the PDA does not closes by the 1 month of age, then it is pathological. This is not physiological, because in preterms, as they are premature, it is if the PDA is present, then that is mostly physiological because of immaturity of the baby, and it will close on its own sometimes, and sometimes we have to give them the ibuprofen and indomethacin. But if the PDA persists in a full-term baby, 38 plus weeks, and it persists up till 1 month of age, then it is not physiological, it is pathological. It is going to cause signs and symptoms and the failure to thrive if it is large defect, and we have to close it by the surgical. And in the term babies, it does not closes with the pharmacological intervention. You need to remember that. And in term infants, basic thing is that the ductus wall, the wall of the duct basically is deficient in both the mucoid endothelial layer and the muscular media, muscular media, that is the two things you may not, you should, I am just telling you for your concept. It does not need to remember these things, that it is deficient in the mucoid endothelial layer or the muscular layer. You just need to remember that in term infants, if it persists, then it is pathological, and it's going to have, if it is large defect, it's going to cause signs and symptoms and even the heart failure. And in term, you have to close it surgically. It does not respond to the pharmacological intervention. Usually 90% does not respond. But in preterms, it is basically because of the prematurity, so it is physiological. It usually closes on its own, or sometimes you need to give the pharmacological intervention, that is the ibuprofen and indomethacin, and it closes. So it does not cause such most signs and symptoms to the baby which are affecting its health. And so that PDA is common problem in premature infants because the smooth muscles in the wall of the preterm ductus is less responsive to the high PO2 and therefore less likely to constrict after birth. So what we talk about, increased PO2 is going to cause the closure of the ductus after birth. But as the baby is premature and its smooth muscles has not that much developed and they are not that much responsive to the high PO2, they don't know that it's a trigger. They don't recognize that it is a trigger and now I have to close it. I have to close the ductus. So it will be less likely to constrict after birth, and it will persist until the baby has the corrected gestational age, that it will be 38 weeks. And its association will be torch, in which diseases you can see PDA. In the baby there is suspicion of the torch, and among them there will be rubella, and it's going to has the PDA. So you need to remember the torch baby, and among that, if there is high suspicion of the rubella, then the baby is going to have the PDA, and you need to monitor for that. So in each and every, most of the congenital heart disease, I have also given an association. So they can ask you about that this is a torch baby, or they can give the signs and symptoms of the rubella, and what will congenital heart defect you will suspect in this case. So it will be PDA. Similarly, other things they can give, like there is a baby of the Turner syndrome, and what pathology or what congenital heart defect you will see, or they will give the sign and symptom of that congenital heart defect, and then you need to correlate that it is a Turner baby. So what is the most common congenital heart defect in this baby that is usually come? So that in Turner, obviously there is the most common is the bicuspid aortic valve and the coarctation of aorta. So you need to correlate these things. So you need to remember these associations, because there was one question in the previous. Can prolonged labor affect PDA closure after birth? Again, it depends upon the no, it's not going to cause, but otherwise, as you are going to have the stress, catecholamines are going to release, and they are going to close the this PTA. In preterms, it's not going to, it will depend upon their prematurity whether it's going to close or not. While the in term, if it's going to be it's going to open, then it will be a defect of the ductus arteriosus muscular layer. It will not be affected by any prolonged labor. In prolonged labor, there is going to be release, or there is going to be stress, and there will be going to be release of the catecholamine, so it will likely to close the defect as compared to open it. So what is the pathophysiology? Term infant, it may persisting beyond the first week of life. It rarely closes spontaneously, and or with pharmacological intervention, as I already told you about. So in term infant, always suspect that it's pathological. While in the premature, if early pharmacological or surgical intervention is not required in premature infant, it means that if it is not that much affecting the child or premature baby, and in early pharmacological intervention it has been closed, then it's spontaneous, or if it is not that much wide, large defect that we need, it's going to cause the baby into the heart failure, then usually routine is that the PT is going to be closed spontaneously in more instances. So if it does not affect that much to the premature baby, then it's most likely to close spontaneously unless it's so much large defect that it's going to cause the heart failure in the premature baby, then we need some pharmacological or surgical intervention. But in term, always think that it's pathological. So this is the descending aorta, and this is the ductus arteriosus, which is going to connect with the pulmonary artery, and there will be left to right shunting because the pressure in the aorta is high as compared to pulmonary artery. So the direction of the shunt will be from the left to right, and in the pulmonary artery, and from here it will go into lungs, and then it will cause the pooling of the blood in the lungs, and it's going to cause the heart failure because it developed pulmonary edema there. And there will be a continuous machinery murmur in the PTA. You need to remember that. What does mean continuous machinery murmur? It is audible throughout the systole and the diastole. Throughout the systole and the diastole, you are going to listen this. And this is a very typical, whenever you heard it, it will be heard at the left second intercostal space, and that will be a continuous machinery murmur. And why it is called as continuous and machinery? Because it is audible throughout the systole and the diastole. What other findings you will see on the clinical examination? As I told you, continuous murmur beneath the left clavicle. And what is beneath the left clavicle is the second intercostal space. So you will see this machinery murmur in the left second intercostal space. And it sometimes, usually, it even radiate to the back of the back in the interscapular region. If it is loud that enough. Machinery, which means it continues in both systole and diastole, and because aortic pressure is greater than pulmonary pressure in the both diastole and the systole. What else you will see? That there will be a wide pulse pressure that is collapsing on the bounding pulses. What happens here during diastole? The pressure of the pulmonary artery should drop, but it does not happen due to the continuous flow of the blood from the aorta to the pulmonary artery. So there is increased difference in the systolic and the diastolic BP. That will be the wide pulse pressure. What does that mean? Wide pulse pressure, basically it's the difference of the systolic pressure and the diastolic pressure, which is called as the wide pulse pressure. So what happens that when during diastole, what is going to happen when all the blood is ejected into the from the pulmonary artery to the lungs, and then from there to the left atrium, the pulmonary artery pressure should be dropped, but it does not happen because there is a continuous flow of the blood from the aorta to the pulmonary artery. So its pressure will remain the same. So there will be not that much different. Its pressure will be remain the same. So it's going to cause the increased difference in the systolic and the diastolic BP. That will be a wide pulse pressure. You will see on the blood pressure And when you will check the pulses and all the pulses that they're in the brachial pulse, in the radial pulse, even you see if the dorsalis pedis artery, they will all be very bounding pulses, just clicking with your hand. So there will be continuous machinery murmur just below the left clavicle or in the second intercostal space that may radiate to the back in the interscapular region. Along with that, there will be the wide pulse pressure, and there will be the bounding pulses, wide pulse pressure, and the continuous murmur. These are the main three findings they are going to give you on the clinical scenario. And the EKG is usually normal. There will be increased pulmonary vasculature because you are continuously shunting the blood from the aorta to the pulmonary artery and from pulmonary artery to the lungs. So the pulmonary vasculature will be increased. And on the echocardiography, you are going to see what is the size of the defect and what is the level or magnitude of the shunting from the aorta to the other to the pulmonary artery, and what is the pulmonary arterial pressure, and whether there is associated any other congenital heart defects are present or not, and how you are going to manage this case. Whether small or large PDA, you are going to close it, especially in term infant. In medical, you can give indomethacin or ibuprofen, as I already told you. In preterm infants, that definitely causes the closure of the, in 90, you can say 90 to 95% of babies, maybe some 5% babies in which you need the surgical closure. But in term infants, it is less likely. It is only 10% who are going to respond to the indomethacin and ibuprofen, and you have to close it, and you have to close it through the transcatheter closure with intravascular coils. This is a coil which is I have shown you here. You have to close it, and you to prevent the bacterial and arthritis or other late complications. What are the other late complications? Baby, when give ibuprofen, if you are asking me about the indications, okay.
Ma'am, after the diagnosis of PDA, when in the immediate after diagnosis we start ibuprofen, or when we start, I mean this question.
Yes, when you have established a diagnosis of the patent ductus arteriosus, then you need to give the ibuprofen. But it will also depend upon the size of the PDA. If it is a very large effect, then it is very, very less likely that it will respond to the medical management. There are other separate guidelines for the terms and the preterm infants, along with the small and the large PDA management. I have not included in this because this is beyond the scope of your FOP and task.
Yes, okay. Thanks.
Okay, but if you wanted, I will share in the group, and you can read here. So because they are not going to ask you this in the FOP and task, they are going to ask you this in the AKP. So we will cover them in the AKP, inshallah ta'ala. But you give the ibuprofen or indomethacin initially, and the as one has asked, the paracetamol, it is first, and then ibuprofen, and then surgical. Okay, in term infants, in paracetamol, especially in the paracetamol may respond in the term infants, but the researches and the evidence have shown that the paracetamol does not respond in the premature infants. So in the premature infants, you have to give the ibuprofen or the indomethacin. We do not use paracetamol for the premature infants. And further, but we can try it in the term infants. But in that term infants, the evidence and the researches have even showed that even in the term infants, only 10 to 20% are there which are going to respond to it. The other ones are not going to respond. So we have to give the ibuprofen, indomethacin, and then the surgical closure. I will share the table of this management in the group if you want it. So for the surgical closure, and for moderate to large PDA, transcatheter closure with umbrella-like device, and we have to treat the heart failure if the baby is going to present. Obviously, they are going to present with the heart failure, and we have to give them the cardiac inotropes. We have to give them the we have to give 1 minute, Adam. I am going to answer this question. Just give me 1 minute. Just quickly we close it. and I'm going to tell you. And we have to treat the heart failure, that is the inotropes, and we have to give them diuretics, we have to give them the oxygen and the respiratory support. And because we have to prevent the development of the pulmonary vascular disease, which is the increased pulmonary hypertension, which will ultimately reverse the shunt. And ideally, we have to do it at the 1 year of age. So what was the question of 1 minute? How long do you give the ibuprofen? We give, it depends upon the early, as we are giving as the prophylactic intervention, or the baby are the early asymptomatic, or baby is the late symptomatic. So we usually give the, if it is early, like early asymptomatic baby, and we have detect the defect on the echo, then we will start it from the 2nd day of life to the 4th day. It means we are going to give it for the 3 days. And if total we are going to give it the ibuprofen for the 3 days, but when we are going to start it, it depends upon the symptoms. If the baby is like very premature, and we are suspecting that baby is going to have the PDA, as in very premature infants they are going to have it, especially in the very low birth infants, which are going to have the birth weight of less than 1 kg. So we give them the ibuprofen in the prophylactically from the day 1st of life. But if it's not the case, and we are suspecting that there is PDA, but baby has not shown the sign and symptoms, but we detect it on the echocardiography, so we are going to start it from the day of life, from the 2nd day of life, 2nd to 3rd day of life, and we are totally going to give it for the 3 days. But if the baby have shown the sign and symptoms, after that we have started, then we will, that is usually 1 week of age, 7 to 10 days among them. So we are again starting at when the babies have started the symptoms, and we have diagnosed it with the echocardiography, then we will start the ibuprofen, and it will again for the 3 days. And but we will give for the 3 days, and then we will see that whether it has closed or not, and the further management will depend upon that, if the PDA has been closed or not. And that's it about it. And ultimately, if it does not respond to the ibuprofen or indomethacin, then we are going for the surgical closures, and that is the transcatheter closure, the intravascular coils and the umbrella-like devices. And we have to treat along with the heart failure if a defect is lodged. So any question up till now? Or we should go to the next, or acyanotic congenital heart disease with volume overload, and that is the atrial septal defect. And you need to tell me that how is the interatrial septum going to develop in the heart? Anyone remember that? Because it is very easy when you know the embryology, how is the interventricular septum is formed and how is the interatrial septum is formed, then it is very easy to know or understand the pathophysiology. And among atrial septal defect are the 2 types, ostium scandum and the ostium primum. Among that, ostium scandum is the most common, this one. So we will talk about the ostium scandum only because this is only written in your books also. 1 minute. So ostium scandum is the defect in the region of the fossa ovalis, is the most common form of the AST, and is associated with structurally normal AV valves. So where was the ostium scandum located? Anyone remember that in the embryology? I told you I will ask you questions about that. Have you not read about it up till now?
In the upper part of septum, I think, ma'am.
Okay. Okay, I will show the structure in a bit. You need to remember that it is associated with Holt-Oram syndrome. They can ask you about this, and I have, I think, read one question about it. The Holt-Oram syndrome, it is basically, there are many skeletal abnormalities in this syndrome. Obviously, atrial septal defect is in between the septum, but where is the ostium primum is located and where is the ostium scandum is located? How is the interatrial septum is formed? So you need to remember this association. So what is the normal pathophysiology? This was the normal. This is the septum intermedium. From here, there is going to be septum primum, and this is also septum primum. And between there, this is the septum ostium scandum. And then this one green color is going to be proliferate or invaginate here, and it's going to cover the ostium scandum. Okay. Ostium primum was here, but it was closed. First, there was the start of the this interatrial septum here from above, from top. Started, and this was the septum primum, and there was the septum intermedium, and there a defect left. There was a defect that was left by this ostium, this septum primum. This was called ostium primum. This was called ostium primum. Then from the septum intermedium, there was the proliferation to cover this ostium primum, and it has covered the ostium primum. Ostium primum does not exist in the normal heart. And then again from the above part, there was the ostium primum. But then again, there was this part left, this whole defect that is called as the ostium scandum. Then to cover this ostium scandum, there was the proliferation of the neurocrine cells, and that is called as the septum scandum. And then there was also a hole still left there that was called as the foramen ovale, which obviously closes after the birth and become the fossa ovalis. So what is going to happen here? Ostium primum AST. This is what I have told you here. This is the ostium primum, and if a defect is left, then it is called as the primum AST. Ostium primum AST. This is ostium scandum. So why when scandum will be happen? When this septum scandum does not proliferate or is long enough to cover this ostium scandum, then this hole is left, or this defect is left uncut, and this is going to cause the left to right shunt, and this is called as the ostium scandum AST. Now you understand? Okay, this is remember that ostium means a hole or a defect. Septum means you can say a wall. So this is ostium scandum, and the septum scandum has not fully formed, which is going to cause it remain uncovered, and it's going to cause a left to right shunt. So ostium scandum is the most common form of the AST, and we will talk about it only. So
can we say that ostium secundum occurred in the top, and the ostium primum occurred in the lower?
Yes, you can say that, but basic thing is that you need to have an understanding of this concept. Why ostium scandum is in the top, and why ostium primum is in the lower part, and what will, if the ostium scandum is in the top portion and it is going to be a defect causing the atrial septal defect, then what is the underlying pathology is that the septum scandum has not formed that much completely. If the ostium primum is the defect, it means that the septum intermedium has not proliferated to form the septum primum. So you can say that it's in the top, it's in the bottom, but you need to have the basic concept why it is going to be in the lower part and it's going to be in the upper part, and what is the defect, what is the basic pathology which is going to cause these ostiums to remain open. That is the only concept you need to remember. Okay, this is the show. This picture is shown. Here is the atrial septal defect. Okay, so what is going to happen? Left to right shunt here, because left-sided pressures are high as compared to right-sided, so there will be left to right shunt, and then it will come into the right ventricle. Then from here to the left pulmonary to the pulmonary artery, and then from there to the lungs, and ultimately you are going to then pooling of the lungs, which will lead to the pulmonary edema and the heart failure if the defect is large enough to cause a very large shunt. And what are you going to have? You will going to have here a systolic ejection murmur at the upper left sternal border in the middle. or in the middle, and there will be a fixed splitting of S2. Have anyone seen or read the explanation of fixed splitting of S2 in the group which I have posted yesterday? Anyone?
Fixed splitting.
Where is Fizan? Where is Fizan? Dr. Fizan.
I'm Burhanuddin, ma'am. My nickname is Faizan.
Oh, okay. Okay. I was thinking, who is this Burhanuddin? I don't know. Okay, Fizan, Burhanuddin, do you remember the explanation?
Little bit, but you explain it as well. I cannot explain.
Okay. What is the normal splitting of S2 with the respiration? What happens? Anyone knows about that? The second heart sound is basically going to split normally, physiologically in the heart during inspiration. So what is going to happen during inspiration? If you inspire, you can do it right now. Then your lungs are going to expand. So your lungs are going to expand, and they are going to create a vacuum in your chest, and it will lead to the increased venous pressure into the right ventricle, and that will go into the right atrium, and then that will be increased venous pressure from all over the body that is going into the right atrium during inspiration, and then that will go into the right ventricle, and that will go from the right ventricle to the pulmonary artery. So there is increased pressure, increased venous pressure, increased blood into the right ventricle. So it will take a few seconds more as compared to the normal, as compared to the aortic valve to empty all of the right ventricle into the pulmonary artery. So there will be a delay of the that blood to the
No voice. Hello.
Hello, you hear me?
Yes, Mama, there is no voice.
Yes.
Okay.
Connection problem.
Connection problem.
Yes.
Can you hear me?
Yeah.
Yes.
Okay.
Let's go.
Okay, I can't show. I can see many things. No. Okay. So that was normal physiological splitting of the second heart sound that will
Mama,
be only
screen.
happen.
We don't see the screen.
Don't see the screen.
Yes.
Okay,
Yes.
just give me 1 second. What is happening? Can you see now?
Yes.
Okay.
Yes.
Okay. So that was a normal physiological splitting of the second heart sound that was during inspiration. And in expiration, there will be decreased venous return, there will be decreased pressure. So the pulmonary and the aortic valve will close at the same time, and there will not be any delay. So there will not be any splitting. But what happened in the atrial septal defect? There is left to right shunt. The pressure and the blood is coming from the left to the right atrium through the atrial septal defect. So in the inspiration, same phenomena will happen. But what will happen during expiration also? that there is continuous shunting of the blood from the left to right ventricular. So right ventricular pressure is going to high, increase blood flow from the right atrium to the right ventricle, and from the right ventricle to the pulmonary artery. So the same thing what happened during inspiration, that will be the increased pressure, is going to happen again in the expiration because of the left to right shunting of the blood through the AST. So there will be again delay of the pulmonary valve closure during expiration. So that will be, you will hear the splitting of a second heart sound during inspiration as well as expiration in the atrial septal defect. So it is called as the fixed splitting of the S2. So if there is, they have given the normal splitting of the S2 during inspiration in many scenarios. You must have seen in the past recalls. So that is only just for the confusion. So you need to remember that the second heart sound normally splits during inspiration. So whenever it is given in the scenario, it means this is normal physiology. It does not have anything related to any pathology. When there is written fixed splitting, then that is pathology, and most common is the atrial septal defect, along with a systolic ejection murmur along the upper left sternal border. So what other clinical findings you are going to have? Ejection systolic murmur at the right upper left sternal edge due to increased blood flow across the pulmonary valve. Then fixed and the wide split second heart sound due to the right one. If you do not understand right now the fixed splitting, then you can go to the premium group, and I have posted the explanation of this. You can read from there, and then you will be able to remember and understand very easily. So fixed and wide splitting due to the right ventricular stroke volume being equal in both inspiration and expiration. And then there will be a short rumbling mid-diastolic murmur produced by increased volume of the blood flow across the tricuspid valve, audible at the left lower sternal border. It may be present or may not be present. It is not possible to differentiate it much, but it is almost present in each congenital heart disease where there is very much increased blood flow. But these two things are the pathognomic for the atrial septal defect, which you need to remember, and they will give you in the scenario.
But ma'am, sorry, ejection systolic murmur, I think.
What is going to... Yes.
Ejection systolic murmur.
Yes.
Also present in two other conditions. I definitely forgot the name. One is, yes, I think TGA. TGA are quotation of the aorta. I think quotation of the aorta.
Not in TGA. There is no. In TGA there is no murmur.
Quotation of the aorta. Quotation of the aorta. Ejection systolic murmur.
Okay. In TGA, transposition of great vessels. Okay, beta. Okay. In TGA transposition of the great vessels, there is no murmur audible, and the difference is, first of all, there is no murmur, and the second thing is that the TGA presents in the immediate newborn period with cyanosis. That is a cyanotic congenital heart disease, and this is a cyanotic congenital heart disease. That is the atrial septal defect. Second thing is that coarctation of aorta. There is systolic murmur. Okay. There is a on the preductal coarctation of postductal that will present later in the life, and there will be associated sinus symptoms that will be the hypertension in the upper limbs along with all the lower limb pulses. So there will be a very much clear explanation and clear clinical sinus symptoms of coarctation of aorta. In the preductal coarctation of aorta, the baby present in the immediate newborn period, and that baby present with the signs of the heart failure, and that may be systolic murmur present or not present, but the main thing is that there will be differential cyanosis. The lower limbs, lower peripheries will be cyanosed as compared to the upper limbs, and same is the case for the blood pressure. So the total clinical sinus symptoms are totally different. That's why I told you about that. You need to remember clinical sign and symptoms, the presentation type, how the baby is going to present, And along with that, the murmur and the any first or second heart sound, important thing about that, and the EKG and the chest X-ray findings. This thing seems to be very simple, but it is very complicated. I have tried maximum to make it concise for you. But we will talk about the coarctation of aorta next in the next slides. You will then you can see the total presentation of the baby is totally different from the atrial septal defect. Similarly, TGA is the cyanotic congenital heart disease. You have to leave it in this other section. That is not an acyanotic. Ejection systolic murmur you can see in the pulmonary stenosis. That is the closed differential. You can see if you talk about the ejection systolic murmur. But about that, obviously there is the presentation is totally different from about depending upon the degree of the obstruction. So we will see in the further slides all these things which you have talked about, and then you can see you can tell me about it whether you are able to differentiate these things or not. Okay. So what will you see on the EKG? There will be right ventricular hypertrophy and the right atrial enlargement and the right Bundle-Branch block. They could happen. And increased pulmonary vasculature, obviously, because increased shunting from left to right and then to the pulmonary artery and the lungs, and there is a pooling of the lung. And the right atrial enlargement, because there is a shunt at the atrial level from the left to the right. So this is going to be increase, going to be enlargement of the right atria. And in echocardiography, defect anatomy and the shunt size. So how we are going to treat this atrial septal defect? If it is small defect, it can close spontaneously. You can just observe it. Large ASD by cardiac catheterization with insertion of an occlusion device, a large enough to cause the right ventricular dilatation, will require treatment. Okay. Small ASD are going to close spontaneously. For the large, you have to go for the transcatheter cardiac catheterization. And you have to, this is a device which you push the catheter along through the ASD, and then you just push it back, and this device just open up and it just occlude the atrial septal defect, and it's going to close it. And usually we do it at 3 to 5 years of age in order to prevent the right heart failure and arrhythmias in the later life. And the infective endocarditis is usually rare. Okay. Next thing is atrioventricular septal defect. We will just do the AVST and then we will take a 5-minute break, and then we will again continue this these, because still in the acyanotic with volume overload and the pressure overload, we are left with 3 main other diseases, 3 main other defects. So after this AVST, we will take a break of 5 minutes. I think that will be enough, and then we will again continue. So what do you know about the atrioventricular septal defect? How it is different from the atrial septal defect? Anyone know that?
Is an endocardial Cushing defect. I don't know.
Yes, and how? Okay, Abshar is asking, how will ASD child usually present? ASD child usually present in the late childhood. Even it can go into the adolescent, into the adult life, and it can even remain undiagnosed throughout life, or in it usually common with Down syndrome. Okay. So it will be also an incidental finding, and the baby may present with complaint of dizziness or chest pain, or it can be palpitations or the exercise intolerance, but there will not be much significant clinical signs and symptoms which will indicate that it's a congenital heart defect. When the baby will present with such complaints, which can be because of any reason, there are a lot of other diseases, but when you auscultate the heart, you will able to appreciate a murmur, and then you will do the echocardiography, and you will be able to know that this is an atrial septal defect. So there are not much symptoms which will which I can tell you that they are going to pinpoint that this is atrial septal defect, because it is a routine, or it may be an incidental finding on the routine examination. Same is for the aortic stenosis. These two are similar, like present in the later childhood or even in adolescents with
but
unusual.
Why are there so less symptoms? I mean, it increases the pressure to lung, and there is upper both atrial chamber pressure increases. So why does the symptoms present so late, or why there so less symptoms?
Okay, because it depends upon the size of the defect, that is the atrial septal defect. As we talked about the VSD small defect and the large defect, same is the case for any congenital heart disease, and all the sign and symptoms depends on the size of the defect. As I told you, very large AST or very large VST or very large PDA, they are going into the heart failure and they are going to present in the early life with the heart failure sign and symptom. But the small usual but that is not much common. AST, very large AST, which is going to present with the heart failure, it is very uncommon. The very common defects are like large VST and the large PDA, which are going to present with the heart failure in the early life. AST, what the researches and the evidence our book says that they are usually small defects and which do not present in the early life because of this small defect. But when in the later life, when it's continuous left to right shunting and over the period of time it's again and again and again shunting, and obviously then right atrial enlargement, there will be right ventricular enlargement, and then there will be increased pooling of the blood into the lungs, and there may be some degree of the persistent pulmonary arterial hypertension. Then with the passage of time over the many years, when this is happening, then they are going to show signs and symptoms and may present in the childhood or in the even adolescent. But a very large large AST, which is going to present early in the life with the heart failure, it is very less common, maybe rare. So this is the basics of these diseases, which, okay, you understood that. Just remember that this is not 100% or sure shot what I am telling you. These are just common things, common findings, and common signs and symptoms which are mentioned in the books. There is a wide variety of it may be possible that AST is associated with some other underlying congenital heart defect, and then it will present earlier. It may be possible VST is associated with some other like pulmonary atresia, and then it will be present at the birth. So if there is a single defect, 50% chances that there may be some other congenital heart defect. That is only you can see where the baby stands or where the child stands and how we need to manage that. It only depends, we decide after echocardiography and the cardiac catheterization, after seeing all the defects, structural defects, and then seeing all the pressures in all the chambers, and then we decide what we are going to do about this congenital heart defect. So that is the normal thing, is that AST is very small, and so it's not going to cause that much sign and symptoms. Over the period of time when the heart is going to respond, going to be decompensated, then the baby presents with that. Okay, now we are going to talk about the atrioventricular septal defect. They are usually called as the endocardial cushion defect, or that is a old name. Now they are called as the atrioventricular septal defect, and they are the most common with the Down syndrome. This is the association which you need to remember. It is associated and the most common with the Down syndrome. What is the defect in the atrioventricular septum? Complete defect is composed of a large AST, large VST, common and incompetent atrioventricular wall. What is the meaning of these things? How is it's going to be happen? Can anyone tell me? What is your understanding of AVST? Yes, please.
Yes, Mama. Is this means single heart chamber? There is only one chamber?
No. Let me tell you. Again, we are going back to the embryology. If you have, okay, Abshar, obviously there is a mixing of blood, but I am talking about the basic concept, how you are going to mix this blood. When you understand, I will just advise that please remember the embryology of the heart, and these congenital heart diseases will be very super easy for you. And when you know the defect, where is the defect and where is the blood going from right to left or left to right, and then it will be very easy for you to remember what is going to happen on the chest X-ray and what is going to happen on the EKG. So do you remember this septum intermedium, which was our middle septum here? First we made, this was the muscular portion of the interventricular septum, and we made the membranous portion from the septum intermedium. Then there was the AST, as I just told you about that. This was the septum primum from, we covered the ostium primum from by septum primum, and it originates from the endocardial cushion. It originates from the septum intermedium. This is the septum intermedium. We made the septum primum here. We made the membranous portion of the VST here. Then if you remember that, we made initially the valves. Okay. So this is the mitral valve cusp, which was formed by the septum intermedium. Similarly, here is the tricuspid valve curve, which we made from this main thing that is called the septum intermedium. We made this tricuspid valve leaflet. We made this mitral valve leaflet. What is going to happen here? This septum intermedium is defective and it's not going to make anything. This is not going to make anything like this. So, okay. Sorry. So when there is defect of this septum intermedium, that's why this is called as the endocardial cushion defect, because this was made from the endocardial cushion. If you remember the embryology of the heart, I'm not going back to it. So this is missing. The atrial septum primum is missing. Then membranous portion of the VST is missing. Then the tricuspid leaflet is missing, and then there is the mitral valve leaflet is missing. So there is the mixing of blood. So there is a large VST. You can see that we don't have the here the septum primer. Then common and incompetent atrioventricular valves. So there is tricuspid valve leaflet absent, and there is the mitral valve leaflet absent. So we have incompetent AV valve and common. And so there will be large VST because we don't have the membranous portion of the VST. So there is going to be mixing of the blood, but how? As you know that left ventricular pressures are high. So basically, and there are some portions still left of this interventricular septum. This is the muscular portion, and this is the septum primum from the upper portion. So blood, basic direction of the blood will be from the left to right atrium, because left side of the pressures are high, right? But it will be common mixing, but the basic initial shunt will be from the left to right, and one back to the right atrium and the left atrium. So this is going to be a common mixing. This is the basic concept behind the AV septal defect. What it's usually going to present at 6 to 8 weeks of life, and obviously heart failure and intercurrent pulmonary circulation infections usually appear in the early infancy. And there will be a hollow systolic murmur at the left low sternal border. As there is a VST, so there will be a hollow systolic murmur at the left low sternal border, that is pansystolic murmur of the VST. Then there will be systolic ejection murmur at the upper left sternal border, that will be of the AST murmur. And along with fixed splitting of ST, there will be findings of the AST, fixed splitting and systolic ejection murmur. There will be finding of the VST, and then there will be hollow systolic murmur at the apex because of the mitral regurgitation. So at the apex, you can see even that pansystolic or hollow systolic murmur at the apex. So they have shown as the number one is this is the deformity of the tricuspid valve, and here let me erase it. Okay. Number one is showing this is the tricuspid valve, and here is the mitral valve deformities. Second is the atrial septal defect. Third is the ventricular septal defect. So and usually AVST is a complex congenital heart disease. So there is somehow to some extent cyanotic cyanosis is present, and basically we categorize. If it is present, then we categorize it in the complex congenital heart disease, and there is a common mixing as oxygenated and deoxygenated blood. So what you are going to see
given as complete. So what does complete imply here? That there will be complete mixing, or is a complete defect in the walls?
It's a complete mixing.
Okay.
Can you repeat the question?
No, in the textbook, it is like implied as complete. So I was asking, what does complete imply over here in this?
Okay, this is complete. This is complete atrioventricular septal defect.
Okay,
which
so
I
there
have
is
shown.
incomplete one also, or this is the only?
No, major and the most common is this complete AV-AST. In incomplete, there may be some portion of the some atrial septal defect or some leaflet, one leaflet is present and the other ones are missing, but that is usually uncommon. The mostly babies which present with of the Down syndrome which present with AVST that are usually complete. These are the portions which I have seen you. I have shown you that the atrial septum primum, tricuspid, and the mitral valve leaflet and
all
the
the
membranous.
5 leaflets are involved. That is complete.
That is complete. Okay.
Thank you.
Okay, what will you see on the investigation? On the chest X-ray, of course, there will be increased pulmonary blood flow. There will be increased pulmonary vasculature, and even you can see cardiomegaly as all the 4 chambers are involved in here. And on EKG, there will be right superior axis deviation along with right ventricular hypertrophy initially, and with the passage of time, it will become the biventricular hypertrophy. You need to remember this thing that there are only 2 congenital heart diseases which the normal axis of our human body is the left inferior axis. You must know that the normal axis or our normal axis is left inferior axis. But obviously with the congenital heart diseases, usually in the acyanotic congenital heart disease, it is left axis deviation, but in the cyanotic congenital heart disease, it becomes right axis depending upon the structure and all the pathophysiology. So with the depending upon the severity and pathophysiology and other things, this axis may deviate to superior, inferior, or left or right. But a normal is left inferior, and there are only 2 congenital heart diseases in the children which have superior axis, right superior axis. So you need to remember that, and it was question MCQ in the I think task that superior axis is seen in. So one is the AVAST and the other one is the Epstein anomaly. I have written down it in the next slides, so you will just read from the notes. But you need to remember that only 2 congenital heart defects which have superior axis deviation, because normally we have inferior axis, and that are AVST, atrioventricular septal defect, and second is the Epstein anomaly. So how you will manage this case of the AVST? You need to manage the heart failure, that is the symptomatic treatment, and the surgical, obviously then you have to surgically correct the defect, because the risk of the pulmonary vascular disease develops as early as the 6 to 12 months of age. So early surgical repair is mandatory to avoid early pulmonary hypertension and intractable heart failure. So okay, just we will cover this and we will take a break of 5 minutes. Which I mentioned here, pulmonary vascular disease. Pulmonary vascular disease. This is basically Eisenmenger syndrome. They are talking about the Eisenmenger syndrome. What is Eisenmenger syndrome? Can anyone tell me? What is Eisenmenger syndrome? Anyone?
Eisenmenger syndrome. When left
Hello.
right can't live
From
without in the passing of time, it reverses by right to left. It called Eisenmenger syndrome.
In the acyanotic congenital heart disease, which are initially left to right shunts, with the passage of time, the shunt become right to left, and it causes cyanosis. That is called as the Eisenmenger syndrome. And Abshar is saying high pulmonary blood flow due to shunt. No. So what does happen? Because initially it was left to right shunt. So what is going to happen? Left to right shunting over the long period of time. Yes.
Well, there's pulmonary hypertension. Because of the increased pulmonary hypertension, the left to right shunt will change to.
Yes, very much right.
And pressure in right ventricle increases more than left ventricle.
Yes.
Shunt reverses.
Yes, you all are right. Just let me explain it 1 to 2 lines and then we will see. basic is the left to right shunt, but when it happens over a long period of time, what is going to happen? Right ventricular has to respond, so it will undergo. Then what other structure is mainly the left to right shunt? One is the right ventricle, and second is the pulmonary vasculature. So what is going to happen? Pulmonary vasculature responds by increasing the pulmonary vascular resistance plus arterial thickening. It undergoes an arterial thickening, and along with that pulmonary vascular resistance, it will increase the pressure so that the blood is not shunting into this direction. Along with that, it will increase the arterial thickening. Arterial thickening means the arterial lumen will become very narrow. So due to which right ventricular has to do extra work to shunt the blood into the lungs against the high pulmonary pressure. So, and again, there will be increased right ventricular hypertrophy. Ultimately, what will happen that when there will be so much work out by the right ventricle, there will be right ventricular hypertrophy. The right ventricular pressure is going to increase, then the left ventricular pressure, and the shunt is going to reverse. So, from the right ventricular to the left ventricular, if it is at the atrium level, then right atrium to the left atrium, and if it is at the pulmonary or aorta level, then it will be from the pulmonary artery to the aorta. So they will shunt deoxygenated blood to the left side, which will ultimately cause the cyanosis.
So, ma'am,
that will be
Eisenmenger syndrome is cyanotic heart disease.
Sorry, is?
Eisenmenger syndrome is cyanotic heart disease. Okay.
Yes.
It is a cyanotic condition.
It is not a separate entity. It's not a cyanotic congenital heart disease. We don't say that it is a heart disease and that is congenital. It develops over the period of time. If you see that is supposed to, you take the tetralogy of Fallot, that is already cyanotic heart disease, that there is already right to left shunt. So how there the Eisenmenger syndrome will develop?
Yes,
okay?
I got it. Eisenmenger syndrome is not congenital cyanotic, but it is non-congenital cyanotic heart disease. After the time,
yes, it develops with the passage of time in the babies with the congenital heart defects who have left to right shunt initially, and when over the passage of time, over the many years, if it remain untreated, okay, if you have treated the congenital heart disease with the left to right shunt, then it's not going to develop. It happens only in those patients who are going to be untreated for a very long period of time, who initially have the defects which have left to right shunts and they were pink in the room air, but over the passage of time all these changes develop, and then they shunt because they were left untreated. They did not treat the congenital heart disease, so ultimately the heart is going to be burned out, and it's going to cause all these things, and the shunt is going to be then reversed from the right to left, and it's going to become a cyanotic one.
Yes, ma'am. Why it called Eisenmenger syndrome? It is associated with some syndromic feature or what?
No, it's just the name. Maybe on some the doctor who has discovered it or who has just described it, but it's not syndrome. You can say that there is going to be multiple things going to be happen here. Like there is going to be right ventricular hypertrophy. There is going to be pulmonary vascular resistance, increase in the pulmonary vascular resistance, and in turn increase in the pulmonary arterial pressure. Then there is going to be arterial thickening. Arterial lumen will become narrow. So maybe there are many things which are going to happen due to which they have given the name of syndrome. Otherwise, it does not have to do anything which we see in the typical syndromes of our pediatric patients. Okay.
Yes.
Okay, it's just a name.
Okay, thanks.
Okay.
Thanks,
okay. I think we will take the break. Yes, we have to take the break. 5 minutes are okay, or 5 to 7 minutes?
5 to 10 minutes.
Oh, no. Okay, other candidates, students, what you are saying? 5 minutes or 7?
5 minutes is fine.
5 minutes are fine. Okay, yeah. Okay. It's about 10:40, so we will meet again at 10:45. Okay.
Okay.
So are you back?
Yes.
Yes.
Okay. Let's start with the next congenital heart disease, that is the question of aorta, and the very, very important one. Okay, it is a constriction of the aorta. Oh God. It is constriction of the aorta anywhere from the aortic arch to the aortic bifurcation. So what are the two major types? There is the preductal, that is the basically infantile, and the postductal, that is the adult type. Preductal is the constriction just before the PTA, that is the ductus arteriosus, and the postductal is constriction after the patent ductus arteriosus, and its association is with Turner syndrome and the bicuspid valve. And there was a scenario in the previous past papers in which there was given the sign and symptom of the Turner syndrome at the birth and just in the neonatal period, I think in the first day of life. And along with that, they have described the clinical sign and symptoms of the preductal coarctation of aorta, and then they have asked the diagnosis. So the diagnosis was the coarctation of aorta, and but they have just given you the sign and symptoms of this Turner syndrome. Along with that, this preductal coarctation of aorta. So you need to have a very clear concept of what is the preductal and what is the postductal, and how you are going to differentiate it. So this is the pulmonary artery and this is the aorta, and this is here the ductus arteriosus, which is connecting this descending aorta to the pulmonary artery. The constriction that is just before the ductus arteriosus, this is the preductal coarctation of aorta, and the constriction that is just after the ductus arteriosus, here is the ductus arteriosus, and the constriction is just after that. This is called as the postductal coarctation of aorta. How they are going to present. First, we are going to talk about the preductal coarctation of aorta. Usually before the PTA, as after birth, the PTA takes few hours to 1 to 2 days for the closure, depending upon the conditions and circumstances and the developmental and the gestational age of the baby. So usually no symptoms are apparent at the birth before PTA closes. Just remember that PTA has not been closed up till now. There are usually no symptoms at the birth. In severe coarctation, blood is shunted from the pulmonary artery to the descending aorta via a PTA with subsequent differential cyanosis, that is the lower limbs blue and the upper limbs pink. What is this concept? There is a simple cyanosis in which in every limb of the body, there is cyanosis. Like if you see the preductal in the upper limb or in the postductal in the lower limb, right limbs, if there is a cyanosis, the saturation will be less than 90%. It may be 85%. It may be 80%. But in differential cyanosis, what is going to happen that the preductal and the postductal, there is a difference of the saturation. Like in the upper limb, there will be saturation these are pink, so there will be above 90% saturation. But in the postductal, that are the in the lower limbs, there will be saturation that will be less than 75%. So this is the difference between upper and the lower limbs of the oxygen saturation and the cyanosis. In preductal coarctation of aorta, you will see the upper limbs are pink and the lower limbs are blue, and this is going to happen when there is no closure of PTA. PTA is open, so it's going to shunt the blood in from the pulmonary artery to the descending aorta via a PTA. How? Let me show you. Here. This is the preductal constriction, and this is the ductus arteriosus connection. Okay, this is just before the ductus arteriosus, so this is the preductal constriction. So what is going to happen? Before the area or the aorta, which is just before the ductal constriction, this is going to have a very high blood pressure because there is the constriction. So all the pressure is going to be happen here. What is going to happen after constriction? Here, there is going to be very low blood pressure. So when there is very severe constriction and the no blood or very little blood can come from this constriction to this area, there is very high blood pressure in this area and there is very low blood pressure in this area. So the pulmonary, as there is very low blood pressure here, the pulmonary artery pressure will be comparatively high than this area, that is the post constriction area. So the pulmonary artery will shunt blood from deoxygenated blood will be shunted from the pulmonary artery to this part of the descending aorta, which has a very low blood pressure because of its just post constriction. So there will be the deoxygenated blood that is going to be into the systemic circulation and which is supplying to the lower limbs. So you will see this Spider-Man. Just remember this Spider-Man. I have tried to make it for you. I am not that much good in the drawings, but I have just made it so that you can remember that this is the differential cyanosis. The upper limbs are going to be pink or the red with normal cyanosis, because all the blood will be shunted here, that is going to support that is going to circulate into the upper limbs, that is the brain and the upper extremities, while the descending aorta is the one which is going to supply the lower trunk. So this will be the oxygenated blood, and so that area will be, upper extremity will be pink, and here there is the deoxygenated blood shunting from the pulmonary artery to the from through the ductus arteriosus to the descending aorta. So the lower extremity is going to have the deoxygenated blood. So just remember this one. This is called as the differential cyanosis. When you will see the SpO2 oxygen saturation, it will be above 90 and it will be even less than 75%. So this is going to happen in preductal coarctation of aorta when the PDA is open, because the blood is going to be shunted through this PDA because of the pressure differences. What is going to happen after PDA closure? When after few hours or few days, when the PDA is going to close, then what is going to happen? Then the patient is going to develop symptoms within a week of the birth with the closure of the ductus arteriosus. And what will be happening? Poor feeding, congestive heart failure, and the cardiomegaly, and the acidosis, bounding pulses in the upper limb. Because I told you that the area, the aorta, which is just before the constriction, that is going to have the high pressure. So the upper limb is going to have a very high pressure. So the pulses of the upper limb will be bounding pulses as compared to low or absent femoral pulses. As now the PDA has also been closed. Let's talk about this. What is going to happen after PDA closure? Here. Now just remember, see that this PDA has been closed. Okay. Now there is no flow in this descending aorta, or very little, because of the severe constriction. So the pressure here will be high. So this is going to supply the upper extremity, upper trunk. The pressure in the upper trunk will be very high with the bounding pulses, while the pressures in the lower extremities here, they will be very low, or the pulses will be even low, or the femoral pulses even can be absent, and the blood pressure difference will also be very significant, with the higher blood pressure in the upper limbs and the lower blood pressure in the lower limbs. There is also a scenario in the FOP in which there is a very much arguing. I have seen on the many platforms that how the hypertension can be present in the coarctation of aorta. There is a scenario of the clinical sign and symptoms of the coarctation of aorta is given, and you have to sorry, you have to it was an extended matching, and you have to just put the right answer in the form of a clinical sign and symptoms are different given for the different diseases. The answer to that scenario was the hypertension, because there is hypertension in the upper limbs because of the increased pressure just before the constriction. So when you take the differentials of the upper limb and the post and the lower limbs, there will be higher BP as compared to the lower limbs. So the answer to that question is hypertension. Now don't argue about that question and don't ask me again and again. I have to explain it here. Okay, so there is going to be difference between in the blood pressure of the upper and the lower limbs along with the pulses, and differential cyanosis will only be in the preductal phase with the PDA open. After the PDA open, there will be no differential cyanosis. Okay, just remember that. So what is going to happen? Hypertension proximal to the coarctation of aorta, head and the upper limbs. Okay, this area, this is supplying to the head and the neck and the upper thorax. So there is going to be hypertension. And then collateral develops between the proximal and the distal aorta, and there will be hypotension distal to the coarctation of aorta, lower body and the lower limbs. And the distal part, there will be low, very little blood flow. So there will be hypotension, and maybe the femoral pulses may be absent, or there will be radiofemoral delay. What is radiofemoral delay? Anyone know that? What is radiofemoral delay? Okay, usually what is going to
delay?
What is the radiofemoral delay?
Radiofemoral delay.
Yeah.
Maybe
what does
heavy radial pulse or no femoral pulse. It mean or what?
Okay. What does happen usually or normally in the normal physiology? The femoral pulses occurs slightly before the radial pulse. Okay. Normally, the femoral pulses occurs before the radial pulse. This is the thing you need to remember. This is the normal physiology. But in radiofemoral delay, the femoral pulses occur after the radial. That's why it is called as the radiofemoral delay. And it occurs because when blood flow to the descending aorta, because there is very little blood flow to the descending aorta, but we have descending aorta have to supply to the lower extremities. Otherwise, they will be ischemic, there will be necrosis, and they will be just slough off. So this is the nature, and this is the last mechanism that collaterals develop from the descending aorta. So collateral develops from different arteries, especially intercostal arteries, and they are going to supply now the lower extremity and the lower limbs. So the lower limbs are going to be supplied not directly from the descending aorta, but from the collaterals. So that's why there will be a delay, or you will feel the femoral pulse after radial pulse, because radial pulse, the upper extremity is getting the blood directly from the aorta. But descending aorta is not supplying to the lower limbs. They have to be dependent on to the collaterals, and then so that there will be a delay the blood passage, or you can say blood supply to the lower limbs, and you will feel the femoral pulses after the radial pulses. And similarly is that the systolic, the blood pressure is also in the lower limbs is slightly higher, 10 to 20 millimeters higher as compared to in the arms. This is the normal physiology, but it happens opposite in the coarctation of aorta. You see the high blood pressure in the upper extremity as compared to the lower extremity. Okay. So that was about the preductal coarctation of aorta, which was infantile type, and that is going to present in the infantile or in the early neonatal period. The second one is the old adult type, or this is called as the postductal. That is which is going to come after the ductus arteriosus, the constriction after the ductus arteriosus. That is going to present in the older children or in adolescents. That does not present in the infancy. Same sign or symptoms will be bounding pulses in the upper limb, weak pulses in the lower limb, and there will be radiofemoral delay and hypertension in the upper limbs, hypotension in the lower limbs, and there may be short systolic murmur along the left structural border at the third or the fourth intercostal space, and that may transmit to the scapular area. Okay. So you need to remember that this is a short systolic murmur along the left sternal border at the third or fourth intercostal space, and it may transmit onto the back into the left infrascapular area along with all these signs and symptoms. Then you can say that this is the coarctation of aorta. This is the basically difference. Clinical situation here is totally different from the atrial septal defect, which you asked me about, that that is also having the systolic ejection murmur. That is totally different. All signs and symptoms will not be present in these patients. On the EKG, you will see left ventricular hypertrophy, and then there will be a 3 sign or the rib notching. Okay, 3 sign I will show you. And rib notching is because of the collaterals that develop from the intercostal arteries running under the ribs. Okay, due to the development of the large collaterals that will be from the intercostal arteries, which are already running under the rib posteriorly to bypass the obstruction. and then supplying the lower extremities. That will lead to the knotting of the inferior border of the ribs from cause of the pressure effects by these enlarged collaterals. So here is this is the sign, that is, you can say that. And these are the rib notching. Here you can see, maybe this is, here it is clearly visible. This is called the rib notching. This is, you can see that the intercostal arteries are running here. So, and because they are going to supply this is going to cause the rib. You can see this is the rib notching. You can see that. Okay, just give me a second. I need to do something. Who is that? Okay. Okay, done. Now back to this was the rib notching. This is the feature of the coarctation of aorta. You need to remember that. They can ask you what are the they can give you this finding and ask you what is the diagnosis. So what is the management in the preductal coarctation of aorta? Obviously, you need to maintain the infusion of the prostaglandin E1 to open the ductus arteriosus and to reestablish the adequate lower extremity blood flow. And then there is the diagnosis and stabilization, and then you have to go for the surgical repair. While in the older infants, if there is a heart failure, then you can go for the anticongestive measure, and ultimately is the surgery. And the surgery is the ultimately you have to go for the coarctation of aorta. So what is the next? Next is we are left with the two pressure overloads, the diseases, that is the pulmonary stenosis and the aortic stenosis. And after that, we will start the cyanotic congenital heart diseases. So what about the pulmonary stenosis? The valve cusps are deformed to various degrees, and as a result, the valve opens incompetent during systole. Pulmonary stenosis is different from the pulmonary atresia. Pulmonary atresia means there is no valve, okay? Valve formation has not been done. So there is no valve. But in pulmonary stenosis, there is obstruction. There is narrowing of the pulmonary valve, and it depends upon the degree of the narrowing or degree of the obstruction. All the signs and symptoms will present. So its association is with Noonan syndrome and the Alagille syndrome. And you need to remember this, especially the Alagille and the Noonan syndrome. They can ask you here. This is the pulmonary valve, and there could be stenosis. Okay, there could be stenosis just above the pulmonary valve area, that is called as the supravalvular PS. It could be just in the valve, that is the valvular PS, and just below the valve, and that is the subvalvular PS. You don't need to go into so much the complications. I think just you remember what is the pulmonary stenosis, what is its association, and what could be the clinical features or clinical presentations. What is going to happen? As I already told you, critical pulmonary stenosis, severe obstruction, severe right ventricular outflow obstruction. There will be no blood flow or very, very minute to the pulmonary artery, and then from there to the lungs. So there will be the signs of the right heart failure, and the cyanosis is present because of the right to left shunting at the foramen ovale. What is going to happen? Severe obstruction, no blood flow to the pulmonary artery and to the lungs, so that there will be increased pressure, increased blood into the right ventricle, which will backflow through the tricuspid valve into the right atrium. And as the right atrium pressure will increase as a result of the backflow of the blood from the right ventricle, so it will lead to the shunt from the right to the left through the foramen ovale just in the immediate newborn period, and that will lead to some sort of cyanosis. So this is what I was talking about. Only in the critical pulmonary stenosis you can get somehow cyanosis. And obviously right RV failure is going to happen because of that. But in the mild to moderate stenosis and into the severe cyanosis, what is going to happen? Okay, what is I am doing? In mild to moderate stenosis, there will be usually no symptom. just like an ASD. Usually have no symptoms and normal growth and normal development, and maybe in the later childhood or the child present with the palpitations or some dizziness or some yes, because it is happening in the just immediate newborn period when there is the transition of the fetus circulation has occurred from fetal to the neonatal neonatal circulation. So the foramen ovale and arteriosus are going to close in the few hours or 1 to 2 days after birth. So in that period, there could be shunting from the foramen ovale from the right ventricle to the left ventricle. But after it closes, then it will be a very severe surgical emergency for which we have to maintain the opening of the foramen ovale for somehow some mixing of the blood should continue, and maybe we need to undergo for the surgical procedures in the immediate.
But ma'am, sorry. So
yes.
it means severe pulmonary stenosis. It is a duct dependent lesion. So it means we have to open the PDA.
Yes, we have to open a PDA because from the aorta to the pulmonary artery, there will be then shunting, and that blood will go to the lungs, and then it will come back to the left atrium and the left ventricular. Yes, this is a cardiac emergency for which you need to open the ductus arteriosus. But in the mild to moderate stenosis, there will be no symptoms and there will be normal growth and development. And with the severe stenosis, obviously, as your signs of right failure such as hepatomegaly, peripheral edema, and exercise intolerance may be present. It may happen that initially it's mild to moderate stenosis, but with the passage of time, with the changes in the heart, it may undergo from moderate to severe stenosis, and then that child will present with the exercise intolerance and maybe the signs of palpitations and dizziness and the signs of the heart failure. On the clinical examination, yes.
For the opening of PDA, we have to go for medical treatment or surgical treatment.
Medical treatment. In the immediate newborn, you don't. That is a becomes a duct dependent lesion. So you need to undergo immediate period. Obviously, you will need the prostaglandin infusion, and that will open the ductus arteriosus.
Yes. Okay. Thanks.
And this is the other differential of the ejection systolic murmur, which is best heard at the upper left sternal border. This is the differential of the ejection systolic murmur, which we have in the ASD. But there will be no wide fixed splitting of the STO. You need to remember that there may be trill present, and there may be an best heard at the upper left sternal border. And when there is severe, then there may be right ventricular hypertrophy along with that, and you will see a left parasternal heave. Okay, but your difference between these two is basically that there will be normal S2 splitting. There will be fixed wide splitting of the atrial septal which is present in that. Okay.
What about trill? In ASD there is no trill. In pulmonary stenosis there may be trill.
Yes, there is no thrill in the ASD. There may be thrill, and there may be also an ejection click at the same area, pulmonary area. Okay. And there will be right ventricular hypertrophy, right atrial enlargement, and cardiomegaly, and decreased pulmonary vasculature when in the severe form, and there is severe obstruction that there is practically no blood is going to the pulmonary artery, and then from there the lungs, then it will lead to this decreased pulmonary vasculature. On echocardiography, we will see what is the degree of stenosis and what are the pressure gradients across in the different chambers, and what are the associated anomalies. Pulmonary stenosis is usually present with many other congenital heart diseases, heart defects. So it becomes relatively easy for them to survive in the immediate period. Mostly children are asymptomatic. What is the management? But when the pressure gradient across the pulmonary valve on the Doppler echocardiography becomes markedly increased, that is the 64 millimeter, then intervention will be required. And transcatheter balloon dilatation is the treatment of choice in the most children. Okay, you need to pass a catheter, and then you have to dilate the pulmonary valve, and it will be good to go. And this is a finding which is not asked in any paper, but it's just for the sake of your information. It is given in the illustrated. That's why I have highlighted here. Otherwise, they usually does not ask about much about the management in the FOP and task. That is the part of the AKP. So you need to be very clear about the diagnosis, clinical symptom, murmurs, and the heart sounds, and the chest X-ray and the EKG findings. So next is this is the last one, aortic stenosis. Among this part of presentation, the leaflets are thickened and the commissures are fused to varying degrees, obviously, and due to which there will be increased left ventricular pressure because the left ventricular outflow, that is the aortic valve, is they are fused or there is obstruction. So LV, left ventricular systolic pressure, will be increased, and LV wall will become hypertrophies in compensation, and its compliance obviously decreases and diastolic pressure increases as well. Then there is a category which is called as the subvalvular subaortic stenosis. It is a discrete fibromuscular shelf just below the aortic valve. It is not in the actual aortic valve, just below the aortic valve. This is a leaflet present which is going to hinder which is going to obstruct the aortic valve. And it's just because there is an association of this subvalvular aortic stenosis, and that is the Williams syndrome, which is, you need to remember that Williams syndrome is associated with the aortic stenosis and especially subvalvular aortic. And in Williams syndrome, there is developmental delay, Alfin facies, full face, broad forehead, flattened bridge of the nose, a long upper lip, and rounded cheeks, as well as the idiopathic hypercalcemia and loquacious personality. They are very happy babies. So you need to remember that Williams syndrome, they may give you the sign and the clinical features of the Williams syndrome along with some clinical sign and symptoms of the congenital heart disease and ask you about the diagnosis, and that will be the aortic stenosis. Aortic stenosis is usually associated with mitral stenosis and the coarctation of aorta. There is very much likely association of this with them. Okay, this is basically a healthy aortic valve, and this is how it has been fused, and there is very, very narrow pathway through which very little blood flow will travel. Similarly here, this is the normal opening of the aortic valve. This is the closed, and this is the aortic valve stenosis. So you can see that there is a very little opening left and very little blood will flow through this. What will be the clinical feature? Again, in the critical aortic stenosis, in the immediate newborn period, severe stenosis and present in the early infancy within 1 week, and there will be signs of the heart failure because there will be obstruction to the LV outflow obstruction. So no blood or very little blood is going into the aorta. LV pressure will rise and it will backflow through the mitral valve into the left atrium and then back to the pulmonary veins into the lungs, and pulling off the blood flow, it will cause the heart failure. While in the less severe form, it is incidental finding on the routine examination. So there will be normal growth, moderate to severe. There will be reduced exercise intolerance, maybe chest pain on exertion. There may be syncope, and sometimes there may be sudden death if the aortic stenosis remain undiagnosed in the later childhood. So if you do not pay attention to the signs and symptoms, then it may lead to the sudden death. But usually there are no signs and symptoms besides some palpitations or dizziness or 1 or 2 episodes of syncope. We are going to have systolic ejection murmur into the right upper sternal border and radiates to the neck and the left mid-sternal border. In the pulmonary stenosis and the AST, the systolic ejection murmur was on the left upper sternal border. In the aortic stenosis, the systolic ejection murmur is on the right side, right upper sternal border, and it will radiate to the neck and to the left mid-sternal border. It will also accompanied by thrill in the suprasternal notch, and a soft decrescendo diastolic murmur, that is the aortic insufficiency, is often present when the obstruction is subvalvular or in patients with biaortic valve. But these two are the findings, that is the thrill along with systolic ejection murmur on the right side of the upper sternal border along with its radiation to the neck. This is the hallmark of the aortic stenosis which you need to remember. On the EKG, there will be left ventricular hypertrophy, and on chest X-ray, you may see the prominent ascending aorta, otherwise it will be normal. And on the obviously echocardiography, you will see how many number of valve leaflet, what is the morphology, what is the degree of the obstruction, and if there is any associated anomalies, like I have told you, mitral stenosis or the coarctation of aorta is present or not. And in the management, sorry, in the surgical, obviously, you need to go for the balloon valvoplasty and open surgery for extreme dysplastic valves, which cannot be opened through the balloon valvoplasty. Then you need to go for the surgical open surgery, and maybe you need to replace the valve and with the prosthetic valve material. Okay, that was all about the acyanotic with volume overload and the pressure overload. This is a mnemonic which you can use to remember the murmurs, PAS, that is the pulmonary and aortic stenosis or systolic. Okay, systolic ejection murmur in pulmonary and aortic stenosis, while in the PAID is the pulmonary and the aortic insufficiency or diastolic murmurs, and the mitral and the tricuspids are opposite of them. Okay, this is mnemonic. You may have heard about it. Next thing is that about the cyanotic congenital heart diseases. So anatomical congenital cardiovascular defects which results in the systemic arterial desaturation. Why? Because there is left to right shunt. There will be left to right shunt, so there will be mixing of the deoxygenated blood from the right side of the left side, and it is going to cause the cyanosis. They may present with the cyanosis or with shock. We will see who is going to present with cyanosis and who is going to present with shock. And with the long term, as there is a hypoxia because of cyanosis, so they are going to develop the clubbing of the fingers. And there may be increased or decreased pulmonary blood flow. We will categorize on the basis of this blood flow. And all congenital heart diseases have right axis deviation with right ventricular hypertrophy, except tricuspid atresia, which has left ventricular hypertrophy. You need to remember that, okay? Tricuspid atresia and some degree of pulmonary atresia also. So all the other have right axis and deviation and right ventricular hypertrophy, except this tricuspid atresia, and you can also say pulmonary atresia. We will talk about it later when we describe these things. And as I already told you about that, superior axis deviation is in the AV-AST and Epstein anomaly. I have already told you. So how we are going to categorize the cyanotic congenital heart disease: increased pulmonary blood flow and the decreased pulmonary blood flow. Okay, this is the thing which you need to ratify. I can say that because I cannot make you understand these things. You just need to remember this, and we will see the pathophysiology. And if then you remember the pathophysiology, then you will be able to remember whether it is decreased pulmonary blood flow or it is increased pulmonary blood flow. So there are the diseases: TOF, tricuspid atresia, Epstein anomaly, and the pulmonary atresia. They are going to present with the decreased pulmonary blood flow, which means on the chest X-ray will be oligemic. There will be decreased pulmonary vasculature. And these TGA, truncus arteriosus, and TAPV, total anomalous pulmonary venous return, and HLH, hypoplastic left heart syndrome. These are the diseases which are going to present with the increased pulmonary blood flow. Then there is a thing, drug dependency, which is very much important for the cyanotic congenital heart diseases. This is the question which I have also seen in the past recalls, and there were many different answers given for that. I think 2 to 3 questions. But you just, I think the students only see what is the drug. This is a drug dependency they have asked about you, so they are going to mark it just in blindly. You need to see that they have asked about the drug dependent systemic circulation, or they have asked you about the drug dependent pulmonary circulation, because in one question they have asked about the which I have seen in the drug dependent systemic circulation, and in one question they have asked about the pulmonary circulation. but the answer was same for the two which the students have marked. So you need to and then you argue about that, what they have asked, and you don't just see what they are actually asking you about that. So duct dependent systemic circulation is that are those lesions in which the systemic circulation is dependent on the right to left flow through the ductus arteriosus. Okay, so these are the duct dependent systemic circulation, in which systemic circulation is dependent on the ductus arteriosus, and the lesions which are duct dependent pulmonary circulation, in which the pulmonary blood flow is dependent on the left to right shunting from the aorta to the pulmonary arteries through the ductus arteriosus. So in the first one, systemic circulation is dependent on the ductus arteriosus, and in the second one, the pulmonary circulation is dependent on the ductus arteriosus. So this is a list of these diseases. The duct-dependent pulmonary circulations are pulmonary atresia with intact ventricular septum, with VST pulmonary atresia with single ventricle, critical pulmonary stenosis, as we have already talked about, and the TOF with critical right ventricular outflow obstruction. These are pulmonary duct-dependent pulmonary circulation. While the duct-dependent systemic circulation, this is the interrupted aortic arch, hypoplastic left heart syndrome, critical aortic stenosis, we talked about that, and the critical coarctation of aorta. So these are critical coarctation of aorta is the preductal coarctation of aorta. So these are the duct-dependent systemic circulation, and you need to remember it. They are going to ask you one question at least about this. So first of all, we are going to talk about the cyanotic congenital heart diseases with decreased pulmonary blood flow, and which one these diseases are: TOF, then tricuspid atresia, and Epstein anomaly, and the pulmonary atresia. These are the four which are going to present with the decreased pulmonary blood flow. We will cover these four diseases, and after that we will again take a break of 5 to 7 minutes. So what is tetralogy of Fallot? Anyone can tell me what are the four main features of tetralogy of Fallot?
Or have you gone to ventricular hypertrophy, overriding aorta, pulmonic stenosis, and one other type.
Yes, one is a large VST, remaining one.
Yes, large VST. Yes.
As in the ACE and thank you so much, Dr. Burhan. As in the ACE aortic congenital heart diseases, the most common was the ventricular septal defect.
Yes.
Similarly, cyanotic congenital heart disease, the most common is the tetralogy of Fallot. Okay, and there are the four cardinal anatomical features: a large VST, overriding of the aorta with respect to the ventricular septum. Then there will be pulmonary stenosis causing the right ventricular outflow obstruction, and then there will be right ventricular. Okay, screen is not here. Why?
I don't know. Sometimes visible.
The students can see the screen.
It is so.
Yes, maybe it's your network.
Okay, maybe there is some internet issue of your Dr. Fazan. Others can see it clearly.
Right.
Okay.
Yes.
Okay, then there will be right ventricular hypertrophy as a result. And what is its association? It is associated with Dajort syndrome. Okay, you need to remember that TOF is commonly associated with Dajort syndrome. So these are the four major defects. Number one is the pulmonary stenosis, due to which there will be obstruction to the right outflow, and it's going to cause the right ventricular hypertrophy. So along with that, there will be third one is the overriding of aorta, and the fourth one is the overriding of aorta means the aorta is coming upon the intervertebral septum. Instead of its normal anterior position, it's going to just deviate and come in between where the interventricular septum lies. So, and there will be ventricular septal defect. So these are the four things which you need to remember. And sometimes it is also called as the pentology of Fallot. And in pentology, there will be an additional atrial septal defect also. But it's just for your information. It's not what they are going to ask you in the examination. So what are the clinical features? Cyanosis is not present at birth, but with increasing hypertrophy of the right ventricular infundibulum. As the patient grows, cyanosis occurs later in the first year of life. Again, it depends upon usual routine. Is that common thing is that cyanosis is not present at birth, and it usually present later in the first year of life. Baby are usually diagnosed within the first year, but not at birth. But again, it depends upon the it depends upon the degree of the pulmonary stenosis, how much obstruction is present. If it is severe that no blood is going into the pulmonary artery, then the neonatal cyanosis is immediately noted. But if it is mild degree of PS, then initially be seen with the heart failure caused by ventricular level left to right side, and maybe it present with cyanosis later in the first year of life. Who are not initially visibly cyanotic, they are called as the pink fellow or acyanotic. And growth retardation, stunting in unrepaired cases is obviously. So the main thing is that TOF usually not present at birth because there is mild to moderate degree of the pulmonary stenosis. So they are maintaining their circulation. But with the passage of time, that the infundibulum causes the hypertrophy, and there is the increased spasm of that the pulmonary valve infundibulum, and it's going to increase the obstruction of the right outflow, and that is going to cause the cyanosis, and the baby is going to present usually around 8 to 9 months or in the first year of life. So again, sinus symptoms depend upon the degree of the underlying congenital defect, the obstruction, or whether it's atresia, it's stenosis. Clinical features, you see, this is the cyanosis, this is mild cyanosis, this is severe cyanosis, and this is the clubbing. But clubbing develops later after few years when there is ongoing hypoxia, then it's going to cause the clubbing. So what are the clinical features? They usually present with the TET spells. What is a TET spell? It is hypoxic blue. You can say it's a paroxysmal hypercyanotic spell. What is going to happen in the TET spell? Mainly in the first 2 years of life. Usually they present, the baby presents with a TET spell when they are in the first years of life diagnosed with the TOF. And it is triggered by any painful stimulus. When you are going, baby is crying, baby is, there is any infection, viral infection ongoing, or if you have given any painful stimulus, like you are going to take the IV line of the baby, or you are going to prick for the blood sample, baby started crying, and ultimately it's going into the TET spell. What is going to happen? There will be infundibular spasm and reduction of infundibular is a part of the pulmonary valve. Pulmonary valve have many parts, so you just need to remember this infundibular. This is the part of the pulmonary valve. This is what part which is basically present in the at the opening of the pulmonary valve, and when it's going into the spasm, it means it's going to obstruct the pulmonary valve and literally practically just reducing or the flow of the blood across the pulmonary artery. So when the baby cries or anything happen like that, triggering any triggering factor, it's going to increase the infundibular spasm, which will there will be reduction of an already reduced pulmonary blood flow. And if it prolonged, then severe systemic hypoxia and ultimately metabolic acidosis will happen. Span can last from a few minutes to a few hours, and severe spells may lead to even they can lead to the seizures. There may be cerebral vascular stroke or even death. On auscultation, there is very short murmur or no murmur during this spell. So you have seen respiratory distress, increasing cyanosis, irritability and restless, and decreased murmur intensity when there is very severe spasm of the infundibulum. So what other findings you are going to have? Clubbing of the fingers and toes will develop in the older children after a few years. Yes.
What is the difference between the cyanosis and the TET spells? I mean, how do we differentiate? Because it looks almost similar.
Yeah, in the babies which are usually present with TOF in the normal situation, you can say that in the normal their ongoing routine, there will be only cyanosis of the lips, along with that the cyanosis of the nails. That's it. The other parts of the body, like their arms, the face and their trunk, that will not be cyanosed. But when the baby present in the TET spell, whole baby is totally, especially the face is all over there will be cyanosis. So that is when we will see that. And the second thing is that the intensity of the murmur will be in this baby with TOF in the resting phase. When he is in the normal routine, there will be a very loud murmur of the PS. You can see, you can auscultate. But when there is the TET spell, baby is agitated, he is crying, and that is increasing its cyanosis, and the baby's whole face is cyanosed. And along with that, when you try to auscultate the heart, there will be no murmur. You cannot appreciate any murmur. But as it will be clubbed, there will be nails cyanosed, and the baby is still present with the cyanosis. So you will see that it's a cyanotic heart disease. And now the baby is present with the worsening of the cyanosis along involvement of the whole face and the other extremities. So, and there is a diminished murmur, or there is no murmur at all. So it is most likely a usual TET spell. And this is like not, you cannot appreciate, this is easily you can appreciate when you see the baby. And even the babies, if they are older, they can tell you that this is happening. Or if the mother is coming with a little bit like 1 or 2 year old baby who is having TOF, then she will tell that this is baby has gone into a what they usually use the term, they say that baby has gone into a spell. They will use the in the like in our setup we use Urdu, so they usually talk about that baby has a dora. But in whatever the languages, they will tell you that this is the spell. And you will see the baby's whole face will be cyanosed, whole arms, whole hands and the feet will be cyanosed, and there will be no murmur, or very usually there is no murmur on the auscultation. At the resting phase, only lips are cyanosed. They will be, and along with that, there will be respiratory distress. And ultimately, if it is prolonged, then you can see the acidotic breathing is coming from the baby. So this is not going to happen in the normal resting phase, when there will be normal respiratory distress of that baby on which he has settled in the normal routine. And there will be only clubbed and cyanosed nails and cyanosed lips, not the whole face and other things along with that. And there will be no residue.
Also, one more thing, it is usually, it is very commonly said with the this TOF that they squatting in the older children, they squat. So that is only helpful when they start a spell. So it's not there helpful if there's cyanosis. Is that true?
Okay, I am going to discuss in the next slide, inshallah, management, and it will be clear then. Okay. I am going to discuss it in the management part. Okay. Okay. On examination, there will be clubbing of the fingers and toes in the older children, and the loud, harsh ejection systolic murmur at the left sternal border, and there will be single heart sound, or the P2 is soft. Pulmonary second component of pulmonary component of the second heart sound will be soft. With increasingly right ventricular outflow obstruction, which is predominantly muscular and below the pulmonary valve, the murmur will shorten and cyanosis will increase. And this will happen in the TET spell, when there will be increase in fundibular spasm, and the murmur will shorten, or it will be absent, and cyanosis will increase. On the chest X-ray, you are going to have boot-shaped heart, okay, and decreased pulmonary blood flow. As we discussed that TOF is a disease in cyanotic congenital heart disease where there is decreased pulmonary blood flow. So there will be oligemic lung along with boot-shaped heart, and there will be right axis deviation, right ventricular hypertrophy. And all the 4 features of the TOF, tautology of fellow, you will see on the echocardiography. So this is the boot-shaped heart. Has anyone seen ever the chest X-ray of a TOF baby? You can see that this is a boat shape. Here. Basically, this is tilted. Apex is tilted, and here. This is going to form a boat-shaped heart. You need to remember that what is you are going to see on the chest X-ray of a baby with a TOF. So in the management part, obviously, the severe right outflow tract obstruction. Okay. So you need to have a ductus arteriosus to maintain the systemic pulmonary circulation. So you need to give the prostaglandin infusion. Along with that, you need to give the beta blocker, that is a propranolol. We will discuss why we are going to give this. And then surgery, obviously corrective open heart surgery. And with the less severe, you give in routine the propranolol, that is the tablet Enrol, and the surgery at the 3 to 6 months of age. It involves, the closing the VST, relieving the right ventricular outflow obstruction, sometimes with an artificial patch, which extend across the pulmonary valve. We will perform the surgery, but obviously TOF is also not that much simple. It is very much complicated, especially with the passage of time when the collaterals have developed. So you need to go for the cardiac echo, cardiac catheterization, cardiac MRI. So this is long. When they are going to decide for the surgery, then it's a long procedure. So we are not concerned about that. We are just concerned about here the medical management. So what usually they are going to do is that in the test spell management, first of all, what you are going to say to the patient and to the mother, if the baby is older, like if he's 7 to 8 years, don't panic, or especially if the baby is younger, like 1 or 2 years, you need to counsel the mother that don't panic. You need to counsel them regarding this disease, that it's going to all right. Then we have to make the knee chest position and the squatting. If the baby is younger, like 1 or 2 or 3 years, mother can easily hold it, then you need to make a knee chest position. This is the knee chest position where you are going to flex the knees of the baby while putting him on the shoulder. And this is the squatting of the in the older children. They learned it by themselves. This is the nature. This is the Allah's mechanism. This is the beauty of Allah. They ultimately understand that this is the posture in which we are going to be all right, and they just sit down and squat. And what is the pathophysiology behind squatting? It is evident that when they squat and when we make the knee chest position in the babies, it is going to squeeze the femoral arteries. And when you are going to squeeze the femoral arteries, it's going to increase your systemic vascular resistance. And when you are going to increase the systemic vascular resistance, then the pressure in the aorta will backflow, and it is going to increase the pressure in the aorta, which will cause the which will lead to it's difficult to push the blood from the left ventricular to the aorta. Squeezing of the femoral arteries, increase of the systemic vascular resistance, ultimately increase in the pressure in the aorta. When there is increased pressure in the aorta, then LV, left ventricular, will not be able to push the blood through the aortic valve into the aorta. So, and it will reduce the mixing of the blood by shunting into the pulmonary artery. So when the LV will be unable to push the blood into the aorta, it will reduce the mixing, which is already going on from the left to right, from the right ventricle to the left ventricle. So it's going to reduce in such a way that the LV is not going to push the blood into the aorta. It will push back into the right ventricle, and it will cause the increased pressure in the right ventricle, ultimately leading to somehow decreasing the infundibular spasm and pushing it through the pulmonary valve into the pulmonary artery, and it's going to blood then going to into the lungs, and ultimately reducing the cyanosis. So it's a mechanism along with other things. All these things are going to cause this mechanism, which I already told you. Then O2 does not affect that much on the cyanosis, but the main theory is that it's going to cause the pulmonary vasodilation, and ultimately it's going to reduce the pulmonary vascular resistance and increase blood flow to the pulmonary vasculature. Morphine is just for the calmness of the patient, and the propranolol or phenylephrine. What are they going to do? The beta blocker, that is the propranolol, it is going to relieve the spasm of the infundibular part of the pulmonary valve. So when we are going to give it, it will reduce spasm. It will when it is going to reduce the spasm, it's going to cause the opening of the pulmonary valve somehow, and allowing the blood from the right ventricle to the pulmonary artery, and thus in turn increasing the PO2 by pushing the blood into the lungs, and phenylephrine is also going to do the same. Along with that, we have to give the intravascular volume administration and the bicarbonate to correct the acidosis, because whenever there is hypoxia, there is going to be acidosis, and we need to correct the acidosis. Otherwise, it will worsen the TED spell. Severe, and if by doing all these things, the TED spell is not going to be relieved, and it's going to be in the severe resistance form, then we have to intubate, and we have to give the propofol and intubate the patient and put him on the ventilator. Recovery from the spell is usually rapid once the pH has returned to the normal. That's why pH will be returned to the normal when you will correct the acidosis, along with you will provide somehow pulmonary blood flow to reduce the cyanosis and increase the partial pressure of oxygen. So this is how the knee chest position and the squatting and the propranolol beta blocker, that is the Indrol, which we give to the TOF patients, is going to work. And this is the same thing. Treatment, you have to release the pain and anxiety, and you have to decrease the systemic vascularization plus minus increase PVR tachycardia. Okay, this is what going to happen. So this is the circle of the TED spell, which is going to cause, because there is decreasing SVR and increasing the PVR. That is what is going to happen in the TED spell. And what we have to do, we have to increase the systemic vascular resistance, and we have to decrease the pulmonary vascular resistance by all these therapies, which I already told you about, by knee chest position, squatting, by giving propranolol, Indrol, or phenylephrine, by hydration, by treatment of the acidosis, and sedation and intubation if the baby does not revert from the TED spell.
So what
there could be complications.
The first line of treatment if the baby presents with a TED spell in the hospital? I mean, what will be the first choice?
What will be the, sorry, first?
What will the, I mean, the first line of treatment, what is usually given when the baby presents with a TED spell?
When the baby present in the hospital with a TED spell, we make the knee chest position. Usually these are the, because it is usually common in the first 2 to 3 years of 3 years of age, the TED spells. So when the baby present, we make the knee chest position. We teach the mother that you have to make this position, and along with that, we provide him the oxygen through the nasal prongs or the oxygen mask, whatever is available. Third one thing is that we ask them about the Indrol, if they have given the usual dose on that day. If not, then we give them the Indrol. Along with that, we provide them the 10 ml per kg, the isotonic normal saline solution. Along with that, we assume that acidosis have been developed and there's acidotic breathing. If we can see, then we give them the bicarb accordingly. And if after all these things, if it does not settle, then we provide them with the IV phenylephrine. And even after that, if it does not revert, then it's going to be worsened. Then we call the anesthesia, and we start and to prepare for the intubation and sedation. Okay.
Okay, thank you.
And you can give morphine also if it is available in your setup, because in some setups it is not available, and also it has some side effects. So we need to be very cautious when we give the morphine to the pediatric patient. So if it is available, you can give also, just to calm down the patient.
I have seen in my pediatric ward when I was in the posting, Sir used to start the bicarbonate simultaneously with the oxygen. So that was the thing.
Yes, that is the, like, just landed the patient, and you when the baby land in the ER, what you are going to do, you are just going to maintain the knee chest position as the baby will be in the mother's lap. So, and you will attach the you will attach the oxygen, you will take the IV line, and you will provide the normal saline along with the bicarb. This is the main step which you have to do within the 5 minutes. And after that, you are going for the Indrol or the phenylephrine, whichever is available. And the other thing, and especially one thing is that do not prick except IV line. You try one thing is that when you try to prick, or you baby become agitated, and it will trigger the TED spell. So just do the maneuvers which you can do. If it does not settle, then go for the other maneuver, the other things which already mentioned in here.
Okay.
So, what are the complications? Polycythemia, as there is the hypoxemia, you know that it's cyanotic congenital heart disease, so it will lead to the increased erythropoietin stimulation, and it will cause increased RBC production and lead to the polycythemia. And when there is polycythemia, it could cause the sluggishness of the blood flow. So it will lead to the cerebral thrombosis, but it is usually common in the less than 2 years of age. You need to remember that. Less than 2 years of age, baby will present with the cerebral thrombosis or stroke. In the babies who are greater than 2 years, they will present with the fits, fever, and maybe some sort of altered sensorium. That is, they are going to, the diagnosis will be brain abscess. Okay, any baby with TOF less than 2 years, they are going to present with the cerebral thrombosis, that usually in the form of stroke. And any baby above 2 years of age, they are going to present with the fever, fits, prolonged fever, fits, maybe even sometimes refractory, or maybe sometimes altered sensorium, and maybe along with that sometimes stroke. So this is the cause. The cause will be brain abscess, and obviously infective endocarditis, the most important complication of the TOF. So next thing is the tricuspid atresia. So this is also another cyanotic congenital heart disease in which there is congenital agenesis, or there is total absence of the tricuspid valve with no direct communication between the right atrium and the ventricle. So it is usually impossible for such condition to exist. It means to be compatible with the life. So Allah has devised this mechanism that in all these tricuspid atresias, there is about 100% have atrial septal defect, and about 95% have VSTs. And obviously there is going to be right ventricular hypoplasia when there is no connection between the right and the ventricular. So it will be present at birth, but there will be associated with AST and VST to have some sort of mixing and some sort of flow of the blood to the pulmonary circulation. So there is basically no communication between right and left ventricle. And you can see that this is the right ventricular hypoplasia. It's not in the normal size. And there may be some VST and there may be some AST. So AST and VST are important or essential to be compatible with the life in this condition. And it is usually an antenatal diagnosis. You can diagnose it on the antenatal scans. And in neonate, they obviously will present with the central cyanosis, because practically there is no blood flow to the pulmonary circulation, because there is no blood flow from the right to the left ventricle. And there will be single S2 and holosystolic murmur at the left low sternal border. And obviously there will be, as there is no blood flow to the right ventricular, so no to pulmonary artery and no to lungs. So there will be decreased pulmonary blood flow on the chest X-ray. And as I have already told you, this is the only cyanotic congenital heart disease which is going to present with the left axis deviation and the LVH. Why? Because there is practically no connection between right atrium to the right ventricle. So what is going to happen? Here. The blood is going through this right atrium, through the AST to the left atrium. All the blood which is coming from the superior vena cava and inferior vena cava, the left atrium and to the left ventricular, and then from there to the aorta, and to the some blood may, there is VST present, then some blood will be pushed from the left to the right ventricular, and then through the pulmonary artery, and then to the lungs. So there is basically the left axis deviation and left ventricular hypertrophy. And on the echocardiography, obviously you will see the atretic tricuspid valve and the right ventricular hypoplasia, VST and the AST. They are present. And how you are going to manage this? You have to maintain the adequacy of the pulmonary blood flow. And so you will start the prostaglandin infusion to have the blood from the aorta to the pulmonary artery and then to the lungs. And then you have to go for the surgical management. It is a 3-stage surgical procedures. In first stage is performed in the neonates. Second stage, that is called as the bidirectional Glenn procedure. It is usually performed at the 3 to 6 months of age. And then third stage is Fontaine procedure, which is usually performed at the 2 to 5 years of age. But you just need to remember that you need to have this prostaglandin infusion to maintain the ductus arteriosus patency, so that you can have some blood flow to the pulmonary circulation. Okay, so next one is the Epstein anomaly. This is there are some similarities between tricuspid atresia and this one. What is going to happen in this one? In the tricuspid atresia, there was total atretic wall. There was no valve at all. But in Epstein anomaly, there will be downward displacement of an abnormal tricuspid valve into the right ventricle. Okay, it will be an abnormal tricuspid valve and it will be hanging into the right ventricular. So the right ventricular is divided into the two parts by this abnormal valve. What will happen? First part will be a thin walled atrialized portion which will be continuous with the cavity of the right atrium. You can say that it will be a right atrium that will be enlarged downward into the right ventricle. And the second part, smaller portion, which consists of a normal ventricular myocardium, and it will be very small. So enlarged right atrium, and there will be an AST with that. And it is usually happen when the mother has used the maternal lithium use during pregnancy. So it's going to cause the Epstein anomaly. And one other feature was that Epstein anomaly is going to have the superior axis deviation. So this is Epstein anomaly. This is the right atrium. This is the abnormally low downward displacement of the tricuspid valve, valve, and this portion of all the right ventricle, it has become the right atrial portion. Okay, and this right ventricle, it is a very small portion which has been left. So this is called as the atrialization of the right ventricle. This is the dilated right atrium. This is the small right ventricle, and there may be a AST along with that. Tricuspid valve with low insertion and severe regurgitation. Okay. So have you understood the physiology, pathology here? The abnormal hanging the tricuspid valve, which has divided the right ventricle, and the one portion has become in continuity with the right atrium, and the other small right normal ventricle that has right ventricle, and it is very small in portion. So what is going to happen in further? In newborns, RV function may be so compromised that it is unable to generate enough force to open the pulmonary valve in systole. It means that the right ventricular is already small, and sometimes its function is so much compromised that it is unable to generate the force or generate the pressure to open the pulmonary valve in systole. And this is called as the functional pulmonary atresia. This is why it is called as the functional, because in actual there is not pulmonary atresia, but because of the function of the right ventricular, the function of the right ventricle has been so much compromised that it is unable to produce generate that force that will open the valve. So it is called as the functional pulmonary atresia, and sometimes there is true anatomic pulmonary atresia is also present in the Epstein anomaly. So what are the clinical features? They may be asymptomatic when there is AST, or maybe cyanosis at birth, and atrial arrhythmias may be present, and pansystolic murmur at the tricuspid area of the tricuspid regurgitation you can hear. So decreased pulmonary blood flow, as we already talked about, and there will be massive right atrium, and which will lead to the box-shaped heart on the chest X-ray. There will be right bundle branch bulk, right atrial enlargement, and superior axis deviation, and the WPW. And echocardiography, you will see a very large right atrium. There will be AST connection between right and left, and the downward displacement of the tricuspid atresia, and a very small right ventricle you will see. This is what you are going to see on the chest X-ray. This is, you can see very, very large right atrium you can see here. So it is basically you are going to have a very box-shaped heart. You can see that this is box-shaped heart, massive enlargement. Again, you need to open the PDA as it is a duct dependent, because as we talked about the functional pulmonary atresia, because of the RV function compromised. So we need somehow some blood to the pulmonary circulation. For that, we need to open the PDA by prostaglandin infusion. And okay, this is pulmonary vasodilators. Okay, I don't know when I have written that, but I think they have no role in this. Just cut it out. Okay, we just need to open the PTA. We need the symptomatic management, along with that the surgery to correct the tricuspid valve abnormality. That was the tricuspid atresia. Now we are going to talk about the pulmonary atresia. And we have two things in pulmonary atresia. One is with intact ventricular septum, and the second thing is with interventricular septum. Intact mean there is no defect. Okay, there is no defect, there is no ventricular septal defect. It means the interventricular septum is complete and there is only pulmonary atresia present. Then what will happen? What is going to happen? Pulmonary valve leaflets are completely fused to form a membrane, and the right ventricular outflow tract is atretic. It means there is no blood flow to the pulmonary artery from the left ventricle. And obviously there is no VSD, as we talked about. So there will be no egress of blood from the right ventricle. Any blood that enters the right ventricle will regurgitate back across the tricuspid valve into the right atrium. It will get back, and then right atrial pressure will increase, obviously, and the blood will shunt from via the foramen ovale into the left atrium, and where it will mixes with the pulmonary venous blood and enters the left ventricle. So what is it's going to happen? It's going to cause the cyanosis. There is no outflow tract. There is no blood flow to the pulmonary artery, as the pulmonary valve is atretic. So the right ventricular blood will go back to through the tricuspid valve into the right atrium. Its pressure will increase, so it will cause the shunting of the blood from the right to the left atrium through the foramen ovale, and causing the mixing of the oxygenated and the deoxygenated blood. And from there, it is going into the left ventricle and then to the systemic circulation. So in a newborn with pulmonary atresia, only source of pulmonary blood flow occurs via PTA. So we have to maintain the patency of the PTA in the management. So this is what it looks like. There is no, you can see that it is atretic pulmonary valve. It is written here. There is no opening of the pulmonary valve. Actually, it does not exist. So blood will go back into the foramen ovale to the left atrium, into the left ventricle, and then into the systemic circulation. And you have to maintain that duct PTA open to have some pulmonary circulation. So, and what will happen when there will be an intact pulmonary ventricular? There will be a ventricular septal defect. VSD, there will be a VSD along with pulmonary atresia. So there will be mixing of the blood between the two chambers, but there will be a TOF-like picture, and it is a very, very severe form because there is VSD and there is total pulmonary right outflow obstruction. So it's going to present like the TOF, and it is actually a variety of the TOF where there is a severe pulmonary atresia, and the baby, even it is usually incompatible with life if you do not treat in the immediate neonatal period. As the doctor, how they are going to present? As the ductus closes, they will usually present with cyanosis because their only source of blood flow is removed to the pulmonary circulation. So as to representing only aortic layer, it will be single and it will be loud. And usually no murmurs are available for this. Sometimes a systolic or continuous murmur can be heard secondary to ductus blood flow. If you have maintained patency, then maybe you can have some continuous systolic murmur, but usually there are no murmur and they are single and loud as2, and cyanosis when the PTA closes. There will be decreased pulmonary vasculature, as we already told about, and on EKG there will be left ventricular hypertrophy and the right atrial enlargement, and the RV dimension you will see on the echo and the pressures you will see. Management, obviously we have to maintain the ductus patency by the prostaglandin infusion, and we have to go for the surgery to correct the pulmonary atresia, valve atresia. Okay, so that was all about the cyanotic congenital heart diseases with decreased blood flow, decreased pulmonary blood flow. Okay, Now we will take a break of 5 minutes and then we will meet again. Okay. Okay, students.
Okay. Okay.
Okay. Okay. Okay, dear students, let's move back to the cyanotic congenital heart diseases. And now we are going to talk about with increased pulmonary blood flow. We have talked about the diseases which were with presenting with the decreased pulmonary blood flow. That was the TOF, pulmonary atresia, tricuspid atresia, and the Epstein anomaly. Now we are going to talk about the cyanotic congenital heart diseases with increased pulmonary blood flow, in which on the chest X-ray there will be increased pulmonary vascularity. So first thing we are going to talk about is the transposition of the great arteries, that is the TGA. And what is going to happen in this? What is the pathology? Pathology is that the aorta is going to come on the location of the pulmonary artery and going to be connected with the with the right ventricle, and the pulmonary artery is going to be adjusted at the location of the aorta and going to be connected with the left ventricle. So it's going to be totally opposite. So aorta is connected to the right ventricle instead of left ventricle, which is usual routine. And the pulmonary artery is connected to the left ventricle. They have switched their positions, these two great arteries. So the blue blood is therefore returned to the body and the pink blood is returned to the lungs. So deoxygenated blood from the right ventricular will go into the aorta and then to the body into the systemic circulation. And what is going to happen with the oxygenated blood from the left ventricular? It will go into the pulmonary artery and then back to the lungs. So this is the aorta arise from the right ventricle. You can see here, this is the aorta and going to arise from the right ventricle. And this is the pulmonary artery going to arise from the left ventricle. And there must be some mixing. There must be some mixing lesion. That could be AST, that could be VST, it could be PTA or patent foramen ovale. Because without that, it is incompatible with life. So we need to have it. If it does not have, then we need to maintain its patency by the prostaglandin infusion in the immediate newborn period to maintain the circulation and prevent its, it is incompatible with life unless there is mixing of the blood between them. So you need something. Naturally occurring associated anomalies are usually VST, AST, and the PTA, as well as the therapeutic interventions which can achieve this mixing in the short term. Therapeutic intervention means, first of all, if there is nothing available, then you have to maintain the patency of the ductus arteriosus in the immediate newborn period with the prostaglandin infusions. Okay, second thing is that this will be a short-term intervention, because when you will stop the prostaglandin infusion, as there are many side effects of the prostaglandin itself, then again cyanosis and all these things will happen. It will again become incompatible with life. So you have to provide a short-term connection between these two, systemic and the pulmonary circulation. So you can therapeutic intervention involve, you can create an AST, and it will provide the mixing of the both bloods, deoxygenated and the oxygenated blood, and it will relieve, or you can buy some time until the corrective surgery is performed. And its association is with Dijot syndrome. One other association of the Dijot syndrome was the TOF and infant of diabetic mother. You need to remember that. So what is going to happen in the clinical presentation? Cyanosis is the predominant symptom, and it may be profound and the life-threatening. And it usually not detected antenatally. Its presentation is usually on the second day of life. When the ductus closes, so the cyanosis becomes apparent. When the ductus closure leads to a marked reduction in the mixing of the desaturated and the saturated blood, and the cyanosis will be less severe and presentation delay if there is more mixing of the blood from the associated anomalies like an AST. So cyanosis is going to be main presenting symptom, and it usually present on the second day of life with cyanosis when the ductus arteriosus closes, so the mixing is reduced and it present with cyanosis. And if the presentation is less severe, if there is an naturally occurring associated anomaly, that is an AST, and if it is not present, then we'll have to create it with surgery, that is the cardiac catheterization. So there is two varieties. There could be TGA with the intact ventricular septum. It means there is isolated TGA and there is no defect which is connecting the two systemic circulation. So it will be a medical emergency as there is no mixing of the blood. Severe cyanosis at birth and with the ductus cloyer, marked cyanosis, and with acidosis and the hypoglycemia. As I told you that there is no murmur in usually TGA which presents in the immediate newborn period. There will be single accentuated second heart sound because of anteriorly placed aorta. But if there is presentation, it present with VST. If there is VST, then it will be milder cyanosis and there will be manifestation of increased pulmonary blood flow and VST murmur. As there will be deoxygenated blood, there will be oxygenated blood will go to the, if there is VST, then oxygenated blood from the left ventricle is going to the right ventricle and right ventricle is attached to the aorta. So there will be mixed blood which is going to the aorta and somehow you are providing some relief from the cyanosis and you are providing some oxygenated blood to the systemic circulation. So, and there will be a VST murmur in this case if the TGA present with the VST. What you will see on the investigations, you will see on the chest X-ray, there will be a narrow mediastinum along with a egg-shaped heart. Okay, it is given the name as the egg on a string. I will show you in a minute. Egg on a string like this. This is the heart which is egg-shaped and this is the narrow mediastinum. So it gives the appearance of a egg on a string. That's why it is called this. And there will be increased pulmonary vascular marking. Because the all the blood from the right ventricle is going into the aorta and from the aorta into the lungs. So there will be increased pulmonary vasculature. And EKG will be normal and interior aorta on the echocardiography, you will see the switch position of the aorta and the pulmonary artery because usually aorta is posterior and pulmonary artery is anterior. As you remember, we have talked about this in the embryology. So their positions are switched now, and aorta is anterior and pulmonary artery is the posterior, and there will be maybe associated defect like the VST or the AST. So you will see what is the basic structural defects present there. So this is an egg-shaped heart and this is narrow mediastinum here. So they basically have given the name of egg on a string, or even you can see egg-shaped heart, then it will be enough. This is typical like egg-shaped heart here. So how you are going to manage this case? Obviously, the key is to improve mixing. So you need to have prostaglandin influence to keep the ductus open and to allow the mixing of the blood. That is really essential. But that will be only a timely or short-term intervention pharmacological in the immediate newborn to buy the time. The next thing is that it is performed at the bedside. You need to perform a balloon atrial septostomy, in which it means you have to create an AST. This is what I have written here. The basic concept is that you have to create an ST to allow the mixing of the blood so that you can reduce the degree of the cyanosis and somehow you can provide the oxygen to the systemic circulation. So a catheter with an inflatable balloon at its tip is passed through the umbilical or femoral vein through the right atrium and the foramen ovale. The balloon is then inflated within the left atrium and then it is pulled back through the left to the atrial septum, and this tears the atrial septum, renders the flap valve of the foramen ovale incompetent, and so allow the mixing of the systemic and the pulmonary venous blood within the atrium in turn, which means you have created an atrial septal defect to provide the mixing of the systemic and the pulmonary circulation. This is what you need to do if you don't have any interarterial, interatrial or interventricular defects, because without this, the baby will be unable to live, and this defect is incompatible life without this mixing. And what is the definitive treatment? You have to do the arterial switch procedure, which means that you have to place the pulmonary artery its right place with the right ventricle and anteriorly, and you have to place the aorta posteriorly with connection to the left ventricle, because there is no other way these babies can survive. So that is the definitive procedure for the transposition of the great arteries. Okay, we are done with DDA. The next thing is that defect is truncus arteriosus. As I have I told you about this in the when we read about the embryology. Truncus arteriosus was the upper chamber in the heart tube which we have formed in the embryology, and it divides into the pulmonary artery and pulmonary aorta. But what happens in this defect? There is a single arterial trunk, that is the truncus arteriosus, which arises from the heart and supplies the systemic, pulmonary, and coronary circulation. It means it has not been divided into the pulmonary artery and the aorta. It is present as it is in the embryology, while in the embryology form, like while it was in the fetal heart. Okay, it has not been divided into the pulmonary artery and the aorta, and so there will be mixing of the blood, and which are going to provide the pulmonary circulation, systemic circulation, and the coronary circulation. A VSD is always present, with the truncus overriding the defect and receiving the blood from the both and the right and the left ventricles. So here they have shown this is the truncus arteriosus, and this is the single trunk leave the heart, giving rise to both aorta and the pulmonary arteries. So single trunk, and this is again after arising, it is going to divide into the pulmonary artery, and then it is going to divide into the aorta, and there is only one semilunar valve, that is the truncal valve here. Okay, this is the here, and this is a large VSD. This is the VSD, and this is the common origin from the right and the left ventricle of this truncus arteriosus, and there is a common valve, that is the truncal valve. There is no separately pulmonary and aortic valve. After mixing of the blood, then it is going to divide into the pulmonary artery, and this is then aorta. And then they are supplying respective circulation, the mixed blood, deoxygenated and oxygenated blood. So what will be the clinical features? In the immediate newborn period, a murmur and the minimal cyanosis. PVR is high, so high pulmonary blood flow, normal. So pulmonary blood flow will be normal. As in the immediate period, you can see a minimal cyanosis because the pulmonary vascular resistance immediately falls, but still it's going to fall further in the next few days, like about 1 to 2 weeks. So that's why initially the pulmonary blood flow will be normal because of somehow high pulmonary vascular resistance. But after the 1 to 2 months, when it falls, pulmonary blood flow begins to become torrential because common blood is coming and there is no that much pressure gradient across the right and the left ventricles and the pulmonary aorta and the pulmonary artery and the aorta. So they are going to be mixing of the bloods and mixing of the pressure. So pulmonary blood flow is going to become torrential, and the clinical picture is dominated by the heart failure with still mild cyanosis. On examination, you are going to have a single S2 along with systolic ejection murmur along the left sternal border. Obviously, you are going to have the increased pulmonary vasculature on the chest X-ray along with cardiomegaly. And on EKG, you are going to have biventricular hypertrophy. And on echocardiography, you are going to see the single trunk from the right ventricle and the left ventricle arising. And there will be mixing of the bloods, and you will measure the pressures accordingly. And what you are going to do for these management, you are going to correct surgical correction. Obviously, is the mainstay of the treatment. And if there is a heart failure, then you have to manage it with the inotropic support, with the diuretics, with the oxygen and the respiratory supports. So this was all about the truncus arteriosus. Now we are going to talk about the total anomalous pulmonary venous return. You just need to have a basic concept of the underlying pathophysiology, what is the basic defect, and from where the shunt is coming, and from where the mixing is going on. And then you can easily tell about the sign and symptoms and what you are going to see on the clinical picture and the investigations. So TAPVR, it is the total anomalous pulmonary venous return. What is going to happen here? The pulmonary veins, which are draining oxygenated blood from the lungs into the left atrium, they have been switched from the left atrium to the right atrium. So practically, you are not receiving any blood, oxygenated blood from the lungs into the left atrium, and then to the left ventricle, and then into the aorta and systemic circulation. So what is going to happen? Pulmonary veins drain into the right side of the heart. If they drain into the superior vena cava, then it is called as the supracardiac TAPVR. If they are going to drain into chronic sinus, then this is called as the cardiac TAPVR. And if they drain into the inferior vena cava, then it is called as the infracardiac TAPVR. And this is a very, very most severe form of the TAPVR is the infracardiac. Clinical presentation will be cyanosis as no O2 blood to LV. So practically there is no blood, oxygenated blood to the systemic circulation. The baby will be present with cyanosis, respiratory distress. There will be heart failure, and there may be systolic ejection murmur. You can have. But his presentation is so much obvious that you straightforward go to the echocardiography and you see that there is abnormal pulmonary venous connections. On EKG, there is right atrial enlargement and the right ventricular hypertrophy. On chest X-ray, there is obviously increased pulmonary blood flow, and there is snowman in a storm appearance. I will show you that. This is what you are going to have. This is the head of the snowman, and this is the trunk of the snowman, and this is the increased pulmonary vasculature. So that's why they are going to, this is called, this is the snowman in the snow appearance, because there is increased pulmonary vasculature. That's why they have given this name, a snowman in the snow appearance. Okay, and how you are going to manage? You have to, it is a cardiac emergency, and you have to emergency surgically correct it in the emergency in the immediate newborn period. So this is called as the cardiac emergency. So the last topic of our today is the hypoplastic left heart syndrome. What is going to happen in the hypoplastic left heart syndrome? There is going to hypoplasia of the left side of the heart. Almost all these things like hypoplasia of the left ventricle and the ascending aorta, along with stenosis or atresia of the mitral and aortic valves. You can see here, there is no mitral valve. There is total atresia of the mitral valve. Then this is a very hypoplastic, very small left ventricle is present. And then there is stenosis are typically no aortic valve present, and this is very small ascending aorta. So there is hypoplasia of the ascending aorta along with hypoplasia of the left ventricle and atresia or stenosis of the aortic valve along with mitral valve. So basically your whole left side of the heart is involved, and it is also an emergency, and this is the most critical and the most sickest of the condition among all the synaptic congenital heart disease. Okay, so cyanosis is not obvious in the first 48 hours of life. A grayish blue skin is soon apparent and denotes a mix of cyanosis and poor effusion. Because ductus will be open. But once the ductus closes, then signs of the poor systemic perfusion and the shock will be obvious. And it is sickest of all neonates presenting with a duct-dependent circulation. No flow through the left side of the heart, so the ductal constriction leads to the profound acidosis and the rapid cardiovascular collapse. So this is this is also a cardiac surgical emergency where you need to take action immediately, otherwise baby will die. Association is with Turner syndrome, trisomy 13, 18, and 21, along with Holt-Oram syndrome and Rubinstein-Tabbe syndrome. These are the associations of the hypoplastic left heart syndrome, where is totally left hypoplasia of the left side of the heart, including left ventricle, mitral valve, aortic valve, and the ascending aorta. So what is going to happen? In the neonatal period, the right ventricle maintains both the pulmonary circulation and the systemic circulation via the ductus arteriosus. And what is going to happen?
Epstein anomaly is not related to Turner syndrome. The box-shaped heart. Epstein anomaly, the box-shaped heart, that is not associated with Turner's.
Box-shaped heart is not in the Epstein anomaly. It is in the, okay, sorry. It is not associated, sorry, to which?
Turner's.
Sorry?
Turner's.
Epstein anomaly is not associated with?
Turner syndrome.
Turner syndrome?
Yeah.
It is.
I'm asking as a question, is it not related, associated with it? On the hypoplastic
Okay.
one?
No, abstain anomaly, I have not read anywhere that in Turner syndrome they present with abstain anomaly. Maybe it is a rare complication, but I have not read. The usual presentation of the Turner syndrome with congenital heart defect is usually the coarctation of aorta and the bicuspid aorta. It is the most common. You were okay. Turn. It may be hypoplastic left heart syndrome may be present in the Turner syndrome, but it will be, I think, rare. It is not that much common as much the coarctation of aorta and the bicuspid aortic valve in the Turner syndrome. Okay.
Okay.
Okay. What is going to happen here? The blood in the LV, which is going to come, it's going to back regurgitate into the left atrium because the aortic valve is atretic and the ascending, there is hypoplasia of the ascending aorta. So in the left atrium, and then from there it is back to AST or through the foramen veil into the right atrium, and from there to the right ventricle, and from there to the pulmonary artery, and then to the PDA through the PDA to the aorta. Why? Because this is ascending aorta is hypoplastic. So there is actually no blood flow through it. So this pressure will be low, where pressure will be high. So the shunt will be here from the pulmonary artery to the aorta through the PDA, and so it will try to maintain some circulation through PDA and this ductus arteriosus. And what you are going to see on the obviously increased pulmonary blood flow as blood is pulling back from the LV to the RA to the left atrium, and some to the back through the pulmonary veins into the lungs, and some into through the foramen ovale or the AST into the right atrium. And there will be cardiomegaly, right atrial enlargement, along with right ventricular hypertrophy because of the left to right shunting through the atrial septal defect and or the foramen ovale. And obviously you are going to see the hypoplastic left ventricle on the echocardiography, stenotic or atretic mitral, and the aortic valve. Whole of the left side will be hypoplastic. Management, it is an emergency. It is an emergency. It is the most critical form of any congenital heart infarction to maintain the ductus arteriosus patency. And surgical procedure, you have to correct this defect, that is the aortic valve atresia and the ascending aorta hypoplasia. So you have to surgically correct all these things, and if the surgery is performed at time with the less complications, then there is 90 to 95% survival rate with surgery, but without surgery 100% mortality rate in this hypoplastic left heart syndrome. So this was the last, I think, congenital heart disease. Finally, I am done with it. These are the tables which I have collected for you. These are the summaries. I'm not going to repeat all these things. These are just the summarized form, whatever I have told you. Most of the things are given in these tables. So you can easily revise from here if you are in emergency or at the end of the, just 1 to 2 days before the exam. You can easily revise these things. Their clinical pictures and their clinical examination findings, their chest X-ray findings, their ECG findings, all is given in these tables. So you can have this PDF. Obviously, you will have it. So I think
the
that
PDF that is uploaded on MedPrepOnline website, it's not like we are not able to make it full screen. It's only a
you are
very
not
small.
able to. Sorry,
Yeah.
you are not able.
I'm not able to make it full screen. I cannot zoom it.
Okay.
Yeah, zoom it to full screen. So it's actually very difficult to study like that because the font and text are very small.
Okay.
So if you can send it separately to the Telegram group, that would be very helpful.
Okay. Okay, let me talk about it to the admin. and then we will sort out.
Or if they can change the setting, because the Zoom video is fine, we can zoom it,
Okay.
the recording of the video, but the PPT is very small. I mean, it's not possible
Okay.
to strip it like that.
Okay. Okay. Done. Okay. Let me talk about it, and we will sort it out, inshallah ta'ala. Don't worry about it.
Thank you.
Okay.
Yes, Mama.
Yes.
We have done cardiology. Mostly now, according to the cardiac diseases, we have done the congenital heart diseases. In this system, there is another diseases. Those diseases, what we should do?
Okay. Yeah, there are other acquired heart diseases. Among them, there is rheumatic heart disease, infective endocarditis, and acute myocarditis. I can teach you if you have time. I think it's quite long lecture, so that's why I opted out, so that we will not able to complete it in the given time. But I have already given you will be given that in the PDF file. But if you want me to go through it, I can go easily right now. If we take 5 minutes break and after that we can go through it, is it fine with all of you?
No problem, Mama. Now we have started more than 4 hours. We are here.
No problem.
We can read. Yeah.
How about having a break and coming back, or you upload it to the site? Which one is?
Yeah. We shall read. We shall read. No problem. If there is some questions, we shall ask you in our group.
Let me just give you an overview of that. Will show you the slides, and the most important one is the infective endocarditis. Just let me. Okay.
One thing, infective endocarditis, it is a prophylaxis. It is so important because question come from infective endocarditis prophylaxis.
About that, just give me 1 minute. This is the infective endocarditis. Okay. The main thing which they will ask you about the prophylaxis. I have written down all these things. Most of the congenital heart diseases or the acquired diseases do not require antibiotic prophylaxis. Okay, for any invasive dental procedure or non-dental procedure, any upper and lower GI tract, that is the surgery or any urological, they don't require any prophylaxis. When to consider the antibiotic prophylaxis? These things you need to remember when you have to give the prophylaxis. Whenever there is a prosthetic valve involved, they have replaced that material with a valve with the prosthetic valve, or there is any prosthetic material is used, then you need to give the antibiotic prophylaxis. And among the congenital heart diseases, any type of cyanotic if it is cyanotic congenital heart disease, then you have to give. But if it is acyanotic, like aortic stenosis or ventricular septal defect, then you don't need any type of prophylaxis. And any type of congenital heart disease, cyanotic with a prosthetic material, whether placed surgically or the percutaneous techniques, up to 6 months after procedure of lifelong, you need to give that. The chlorhexidine mouthwash, these are not recommended. Okay, I have written all these things here. Maintain good oral hygiene. Then symptoms, you have to tell them when to seek expert. Chlorhexidine mouthwash should not be offered as prophylaxis against infective endocarditis to people at risk undergoing dental procedure. And if any episode of infection in people at risk of infective endocarditis should be investigated and should be treated accordingly. And you need to avoid the invasive procedures, including body piercing and tattooing that is you have to stress on. So only this thing you need to remember. These are the guidelines given in the pediatric bedside guidelines. You need to give this only these people need to give the prophylaxis. Even chlorhexidine mouthwash are also not recommended. Usually question like, this is a baby of the BSD and who is going to have a dental procedure, so what will you advise for the prophylaxis? So there are many things given, but you have to select that no prophylaxis is needed for. Even chlorhexidine mouthwash is also not recommended. Okay. Among infective endocarditis, this is the most common question which they ask.
Yes,
and among acute yes.
Sorry, that what is the relation between body piercing and infective endocarditis?
because you you don't know about the instruments, what they are. You can, like in Part-1 endocarditis, it's just not that you are having another and congenital heart defect and that is going to be infected. You can get it from the central venous lines. You can get anywhere you have any invasive procedure. So this is what is the rationale, that when you are going to have the body piercing through instruments, you don't know that are sterilized or that is what going to happen. That can cause infection, which can lead to, because there are different. I have also written down here. I think I should. There are different organisms which are going to cause the infective endocarditis through different procedures. Like Viridans group are going to cause after dental procedures. Staph aureus, no underlying heart disease, but IV drug abusers. So this is the same thing. If IV drug abusers can get through the staph aureus, because you don't know they are using the sterilized needles or not, that can infect them with the staph aureus, which can lead to the infective endocarditis. And same thing is for the body piercing and the tattoos. Similarly, if you have the yes.
For infective endocarditis, it is necessary that underlying cause should be present.
No. It should not be necessary. No. You can see here. This is written staph aureus. No underlying heart disease, and it is going to happen in the IV drug abuser. It is not necessary to have an underlying congenital heart defect or acquired heart defect. It can happen in a healthy person without having any underlying congenital or acquired heart disease. So don't limit it to just congenital or acquired heart disease. It can happen in a perfectly healthy people. Like IV drug abusers don't have any congenital, usually heart disease. Okay.
Yes, okay. Thanks.
Okay. Among the acute myocarditis, you are going to have they are going to ask you the name of the organism. So Coxsackie is the most common, and if it is not given, then the second one is the adenovirus. Okay, you need to remember that Coxsackie and the adenovirus, they are going to cause the acute myocarditis, and these are the most common. Most common is the Coxsackie virus. And among the they are going to ask you about the, obviously this is the recent A group step infection. They are going to ask you about the, yes, Dr. Mohammed Kani, we are going to upload it, and Adam, yes, we are going to upload it, don't worry. And about the rheumatic fever, they are usually going to ask you about the diagnosis. Okay, you need to remember that there are the two major criteria. Okay. Jones criteria, major criteria, minor criteria, and then supportive evidence. So among the major criteria, there is carditis, polyarthritis, erythema marginatum, subcutaneous nodules, and syndrome chorea. These are the major criteria. And among the clinic minor, there is fever and arthralgia. And among lab, there is ESR, CRP, and prolonged. And you must have a supportive evidence. This is must one of the group-based streptococcal infection, either through a swab, throat culture, or through the ASOT titer. So basically, they ask you about the ASOT titer. So along with these criteria, you need to have this one that is essential, which is I have already told you, written here. Two major manifestation are one major and two minor, plus there is R. Okay, among this there is R, but there is plus. So you must have this thing along with these two things. Okay, here they all have R, but they have plus. It means you have to have this thing, and you have to then fulfill this criteria separately and this criteria separately. So you need to have a recent evidence of streptococcal infection, either in the form of ASOT titer increased or through the swab culture. This is what they're going to ask you about the rheumatic fever. Okay. So this was all about these three acquired diseases you need to remember.
Yes, thank you very much, Mama. The other question is, what about the clinical cases?
What about the? Sorry?
for clinical cases, plus clinical cases, cardiology. According to this topic, this system, now we have done our lessons. What about the scenarios cases? We have two PDFs for clinical cases, plus clinical cases. According to this system, what we need to do that.
Okay. If you have read all these things which I have told you, I have tried to maximize all the information from the SOP illustrated and the clinical cases books of the TOS and the FOP, and along with some nice guidelines. So I have tried to I have read all those cases and tried to whatever was missing in my presentation, I have incorporated that into my presentation. But if still I would like to advise you that at least one time you should go through the FOB clinical cases and the TASK clinical cases, which I will after this meeting, I will just post the number of numbers that clinical cases of the FOB and the TASK which you need to go through related to the cardiology system. So if you have time, you can go through that. I will advise you go through, because there is written that the clinical cases are written in a systemic approach. So that is very good for at least one time go through. But if you don't go through, then don't worry about that. I have almost covered all the things in my presentation. But I will post the numbers of the cases related to the cardio system in the group later on after this presentation. So if you want to go through that, you can go through.
Yes, ma'am. And extra question: when we go for guideline in recall in the last or
sorry, when we go through the recalls.
When we go for recall in the guideline in the end of the course,
guidelines, we are incorporating the, I have told you the management of the rheumatic fever or infective endocarditis. This is all written in the guidelines. Or the syncope management, I have taken all the management portion part from the NICE guidelines. So I have covered the important guidelines of the cardiac system in this all presentation. Okay. The recalls, we will give you recalls in the cardiac system exam, like you have done. Now you have completed the cardiology system. Okay, now you are going to read it for 2 days, and then after 2 to 3 days you are going to be given the access of the cardiology exam. That will be about 50 to 60 questions, and then you have to attempt it on the website, and then we will see where you stand and what is your percentage. And almost I have tried to cover all the past recalls along with some other questions in the cardiology system into that cardiology exam. So you don't have to worry about that previous recalls. Okay.
Yes.
I have extracted all the systems questions from all the past papers up to 2015, from 2015 to 2023. So I have all these system-wide questions. So we are incorporating all those into your system-wise examine these tests, which will be after sessions, after lectures, and that will be 90% will be covered in those exams. Okay, if there is any query regarding the answer of any question in those exams, then you can easily ask on the telegram group anytime.
Yes, okay, ma'am. So in the end of the cardiology, you make a mock test.
Yes, mock test. Yes, I'm talking about that mock test.
Okay,
yes,
you will be having you will be having like 2 to 3 days now. I think 2 days, because your next system is going to also starting from I think 8. So you will be having 1 to 2 days. You just read your cardiology all from the presentation or the books from wherever you want to read. Just understand it, and then you will be given the access of that cardiology mock exam on the website, and then you will attempt that, and it will cover almost each and everything, inshallah.
Okay.
Okay. Thank you for your time, Mama. My last question is, according to this PDF, if you read this PDF, is it important again to read SOP or illustrated, or this file is enough for us to read?
Yes, I will say that it is enough to read this presentation because I have read this presentation from the SOP and the illustrated textbook. But sometimes it happens that some students are not satisfied with the extra material or from the by reading the presentations or anything else. They prefer to read the textbook. So if you are that type of student, you want to read that textbook, you can read book, but it will be the same thing, and you will get a very good understanding after reading this presentation or after having this lecture. So if now you, after having this lecture, you want to go for the textbook reading, you can go, and it will be very easy for you to understand each and everything.
Thank you.
Okay.
Thank you, Mama. I think
Thanks,
we have.
ma'am.
Okay, thank you so much. I will end the session. I think
I wanted to say something, if it's okay.
yeah.
Can we like have 1 hour class or half-hour class for discussing clinical cases? Like, it would be better. We would know how to, I mean, figure out how to answer and everything, because the type of questions are very different. Like we are not used to it. So after supposedly this cardiology lesson has ended, we can discuss some clinical cases or questions, like a very small class, if you're okay with it, because that really helps discussing clinical cases.
Okay, you want to discuss the like past recalls or like clinical
Yeah,
cases of
mixture, yeah, clinical cases and like not a lot, like some like 3, 4 or 5, 6, so we can have an understanding of how to answer and what to figure out, because sometimes the questions are so long and we don't have time, right? So we need to be quick in our comprehension. So it will help in this discussion would help, even if it's half hour, because we have 2 days. So we can, if you can arrange one class for that after every system that we have done, like cardiology is done, neurology, like that. It's really helpful if you're up with it. So, because yeah, Telegram is fine, but it makes a difference when it's face to face. I mean, like this on Zoom.
Okay. We will discuss about this, and then we will let you know, inshallah ta'ala. It will
Yeah, I
not be
hope you
possible.
understood what I'm trying to say. I mean,
Yes,
I'm not
I totally
requesting
understand.
another 3, 4 hour
Don't
class.
worry
Yeah.
Yeah, don't worry about that. I totally understand. And
Yeah.
we will discuss about, I will discuss about it to the admin, and then we will manage it somehow. Okay?
Yeah, because I
Don't worry.
attempted some questions on past tests also, and also those questions that you have given. And the
Okay.
way of answering is just very different that we are used to. So,
Okay. Okay, let me just discuss about it, and then we will obviously inform you. Okay?
okay, thank you so much. Thank you.
In any case, if it's still not possible, then it is you can send me even in the group or even separately. You can talk to me, and if you are not able to understand anything about related to any query, you can send me, and I can totally, I will obviously
That
reply.
is there, yes. That is there in Telegram. I know that, but a separate discussion gives a lot of insight and clearance. So that's always much more helpful. Especially now the
Okay.
cardiology is over and it's fresh in our minds.
Yes, I know that. Okay, let me tell I'll discuss it, and then I will get back to you, inshallah ta'ala. Okay.
Okay. Thank you.
Oh,
Good night.
okay. Good night. Okay. Thank you so much, Adam. Yes, please give a read to the cardiology, and inshallah ta'ala you will be on it. Okay. Thank you so much, all of you.
Allah Hafiz, ma'am.
Allah Hafiz.
Allah Hafiz.